All of us are doing this work. The purpose of this workshop today is to do it better. Now let us look at it's an occupational safety issue. It's a patient safety issue. It's an environmental safety issue. Also, it is an attitudinal issue. It is. Hello? Hello?
Yes, sir.
It is an occupational safety issue because doctors, nurses, health workers, doctors in veterinary hospitals, research houses, animal houses, livestock inspectors, all the staff, including security, ambulance staff, any one of us may get HIV/AIDS, hepatitis B or C, skin infections, respiratory infections, accidents. Here, the simplest accident, but more grievous, will be the needle stick injuries, either by means of hypodermic needle, insulin needle, biopsy needle, scalpel blade, pleural tap needle, ascitic tap needle, or razor blade. It's an occupational safety issue. We come for work. I think we should go back for safe. Our staff come to work. They should go back safe. It's a patient safety issue. If a patient comes with for hernia, we should not send him back with hepatitis B or C or HIV/AIDS as a gift. It's a hospital acquired infection issue. It's an issue related to antimicrobial resistance. It's an environmental safety issue. The medical waste may cause soil pollution, water pollution. What is burnt in Bangalore, whether Bangalore or Mangalore, plastic or any organic waste or any open burning, the fumes which contain persistent organic pollutants, 12 in number, important one being dioxin and furans, they may cause cancer, they may cause genetic defects. And these fumes, what is generated in Mangalore can go to Geneva. What is burnt in Geneva can come to Bangalore. It's an environmental safety issue. Friends, I like you to think over how we were able to make so many masks in very short time during COVID pandemic. How we were able to manufacture and supply personal protective equipment in such large numbers. How it was possible to manage tons of healthcare waste. How it was possible to set up COVID care centers across the state. Friends, let us look at what are the strengths in India, Karnataka and Dakshina Kannada district. We have BMW legislation 2016 and amendment 2018. We have training materials developed by Pollution Control Board, MPRI, Community Medicine Department of MS Ramaya Medical College. We have common biomedical waste facilities, 27 in number across the state. We have hazardous waste management facility in Dabaspet. We have engineering technology, medical technology. We have Kayakal program. We have NABH, NABL. We have Lakshya initiative. Weaknesses. I like to request all of you to join me in telling that we don't have any weaknesses. We have few challenges. The metal, hypodermic needle, biopsy needle, pleural tap needle, any of the things, scalpel, blade, they are made of high quality surgical steel. Metallurgists say it has very high melting point. It is recycling is costlier than making it newly. Glass, recycling is possible, but very costly. Plastic, recycling possible, up to 7 times one can do it. Requires centuries to become part of soil. Friends, attitudinal change. I want to ask each and every one of you, is it in our hands. Please think over. Probably attitude and lack of continuous monitoring and surprise inspection by the regulators may be obstacles or threats. All of us are trained in biomedical waste, infection control at some point or the other. All of us already doing. If we look at the opportunities we have in this workshop, we can get more information. We can train others, our colleagues, staff, friends. ಇಲ್ಲಿ ಬಂದಿರತಕ್ಕಂತ ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ನವರು, ಹೆಲ್ತ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ನವರು, ವೆಟರ್ನರಿ ಆಸ್ಪತ್ರೆಯವರು ಎಲ್ಲರೂ ನಾ ಕೇಳ್ಕೊಳ್ಳೋದೇನು ಅಂದ್ರೆ, ಪ್ಲೀಸ್ talk to MPRI people. Get all the presentations of today. Conduct retraining in the sub-centers, primary health centers, community health centers, district hospitals, medical college hospitals, everywhere, veterinary hospitals. Do repeated training. Next, would like to request you, if all of us more than 70 and odd who have joined now, can we do it with dedication? Can ಬೆಳಗ್ಗೆ ಹೇಳ್ತೀವಿ, ದೇವ್ರಿಗೆ ನಮಸ್ಕಾರ ಮಾಡ್ತೀವಿ. ನಾವೇನ್ ಪುಸ್ತಕ ನೋಡಿ ದೇವ್ರಿಗೆ ನಮಸ್ಕಾರ ಮಾಡ್ಬೇಕು ಅಂತ ಮಾಡ್ತೀವ? ಮಾಡಲ್ಲ. ನ್ಯಾಚುರಲ್ ಆಗಿ ಮಾಡ್ತೀವಿ. ಅಪ್ಪ ಅಮ್ಮ ಕಲ್ಸಿದಾರತ್ನ. ಹಾಗೆ ಎಷ್ಟೋ ಕೆಲ್ಸಗಳನ್ನ ನಾವು ಮಾಡ್ತೀವಿ. ಒಂದು ಸಂಸ್ಕಾರ ಸಂಸ್ಕೃತಿಯಿಂದ ಮಾಡ್ತೀವಿ. The challenge I want to throw to all of you is, can we develop biomedical waste management and infection control as a culture in our institution? Objectives of this workshop is introspect, review current scenario, and strengthen strategies to manage biomedical waste and infection control better, both within, that is medical college hospital, district hospital, sub-center, PHC, community health center, district hospital, blood bank, laboratories, veterinary hospital, animal houses, research institution. Apart from that, we should be sensitive to what happens after it goes from our place to the common biomedical waste facility in terms of transportation, in terms of disposal. Meet stipulation of the BMW rules 2016 and 2018 amendment and recommendations of the National Green Tribunal. Friends, I want to ask you, why somebody should come and question us? Why should somebody come and warn us about our recall and list precautions needed in the context of COVID-19 pandemic and such other disasters? I repeat, objective of today's workshop is introspect, review current scenario, and strengthen strategies to manage biomedical waste and infection control better, both within and outside healthcare settings. Meet stipulation of the BMW rules and recommendations of the National Green Tribunal. Recall and list precautions needed in the context of COVID-19 pandemic and such other disasters. I want to throw a challenge to the entire group of people who have joined here today. Friends, please think over. Can we make Dakshina Kannada district the best in biomedical waste management, best in infection control in Karnataka? Why Karnataka? In India itself, we have 7 medical colleges in proximity with the district. Can we do that? I want to freeze by telling one thing. See, we are what we repeatedly do. What we behold, we are. Excellence is not an act, but a habit. If we repeatedly do biomedical waste and infection control well and achieve excellence, we protect ourselves, we protect our staff, we protect the environment, we protect our patients. Choice is ours. Friends, can we make Dakshina Kannada district the best in biomedical waste management, the best in infection control? This is for your consideration, please. Before I request Dr. Ramakrishna Gaud to continue, friends, kindly mute yourself. Kindly close the video. This will help hear better. Thank you very much, friends. God bless all of us.
Thank you very much, Dr. Prithvi, sir, for this inspirational talk. Now I would like to welcome the resource person for the session on Biomedical Waste Management 2016 overview by Dr. B. Ramakrishna Gaud, sir. He is the Professor of Community Medicine, St. John's Medical College, Bengaluru. Over to you, sir.
Thank you. Thank you, Jagadamba. I want to share the screen.
Stop sharing. You can share, sir.
It can be seen, Allah?
Yes, sir. It's visible, sir.
Okay. Yes. So thanks to Sir for kickstarting today's discussion. And Nama Dakshina Kannada district in the Bandirvanta Nama Illa Arogya Sibbandi avarge, both from government as well as from the medical college, and also our colleagues from the veterinary institutions and Ayush stream of health sciences. Nimellargunu kuda namaskara. My name is Dr. B. Ramakrishna Gaud. I'm one of the resource persons for today's discussions. So the task that is assigned to me is the overview of biomedical waste. ಇದರಲ್ಲಿ ಸಾಕಷ್ಟು ಡೀಟೇಲ್ಸ್ ಇದೆ, ಬಟ್ ನಾನು ಆ ಎಲ್ಲ ಡೀಟೇಲ್ಸು ಕೊಟ್ಟಿರುವಂತ ಲಿಮಿಟೆಡ್ ಟೈಮ್ ಅಲ್ಲಿ ಡಿಸ್ಕಸ್ ಮಾಡೋಕ್ಕಾಗಲ್ಲ. ಅಂಡ್ ಐ ಥಿಂಕ್ ಇಟ್ ಇಸ್ ಆಲ್ಸೋ ನಾಟ್ ಇಂಪಾರ್ಟೆಂಟ್. ಸೊ ವಾಟ್ ಈಸ್ ಮೋಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ಫಾರ್ ಅಸ್ ಹೂ ಆರ್ ವರ್ಕಿಂಗ್ ಆನ್ ದ ಗ್ರೌಂಡ್ ಇಸ್ the take-home messages from the rules. There are few other regulatory and other details which are there in the rules that I think our higher-ups will take care of it. But for us, those of us who are managing the hospitals and healthcare facilities, you certainly can expect a few insights in today's discussion, vis-a-vis the rules. So, yes. Now, ಇವತ್ತಿನ objectives ಏನು ಅಂದ್ರೆ, just to give you an overview of the biomedical waste rules and few take-home messages from the rules, and most importantly, few things, details from the rules which will enable us to put up systems for waste management in the hospitals. So rules, ellaru now rules and takshana rules andre we think it is about what to do, what not to do. ನೀವು ಇದು ಮಾಡಿದ್ರೆ ಅದಾಗತ್ತೆ, ಅದು ಮಾಡಿದ್ರೆ ಇದಾಗತ್ತೆ, ಇದು ಮಾಡದಿದ್ರೆ there are certain legal obligations. No, but biomedical waste rules is not like that. Well, there are certain penalty provisions, but most important things from the biomedical waste are, it actually is our good friend. It's like a guide. It will tell us, how to do and how best we can, do things vis-a-vis biomedical waste. So the rules is a compendium of, how to do, module tara. All of us are familiar with the modules. It's like a module, but ಅದನ್ನ ಬಿಡಿಸಿ ನೋಡ್ಬೇಕಾಗುತ್ತೆ. ಬಿಡಿಸಿ ನೋಡಿ ಅರ್ಥ ಮಾಡ್ಕೊಂಡ್ರೆ it is actually helps us like the way a guidebook helps. Now, ಪ್ರಪ್ರಥಮವಾಗಿ ಬಯೋಮೆಡಿಕಲ್ ವೇಸ್ಟ್ ಅಂಡ್ ಹೆಲ್ತ್ ಕೇರ್ ವೇಸ್ಟ್ ನ ಡಿಫರೆನ್ಸ್ ಏನು? ಬಯೋಮೆಡಿಕಲ್ ವೇಸ್ಟ್ ಅಂದ್ರೆ ಎಲ್ಲಾ ತ್ಯಾಜ್ಯ ವಸ್ತು, ಜೈವಿಕ ತ್ಯಾಜ್ಯ ವಸ್ತುಗಳು which get generated while our veterinary friends take care of the health of the animal stock, and our Ayush colleagues delivering health through their health system, and also coming to the medical fraternity, medical side, the waste that we generate while taking care of the patients, while doing research, while doing outreach camps, immunization camps, ityadi. So ella ee waste ellanu kuda comes under the biomedical waste. Healthcare waste andaga it just narrows down the scope to the medical waste that we generate while delivering healthcare, mostly in healthcare facilities. So we must keep the broader perspective, and we have to have a view, a biomedical waste management view, and healthcare waste is a part of the biomedical waste. ಸೊ ಇವತ್ತು ಆ ಪರ್ಸ್ಪೆಕ್ಟಿವ್ ಇಂದಾನೇ ನೋಡೋಣ. ಇವತ್ತು ಆಲ್ ಆಫ್ ಮೈ ಡಿಸ್ಕಷನ್ ಇಸ್ ಗೋಯಿಂಗ್ ಟು ಬಿ ಬೇಸ್ಡ್ ಆನ್ the perspective of biomedical waste. So whatever the few things that I mentioned today in my small topic, in this short time, it is relevant to our Ayush stream of health sciences and also our colleagues who are in the veterinary institutions. Ellargunu kuda anvayisutte whatever the discussions we are going to have in the next 30 or odd minutes. Now, what is the difference between management and disposal? Friends, please, whenever we talk about biomedical waste, it is management and not disposal. Disposal is one step in waste management. So, and we should not talk in terms of biomedical waste disposal. Sumar sala nave antivi adna. No, let's change our narrative and let's call it as biomedical waste management. Disposal, like I mentioned, is one small step in waste management. Waste management andaga, it basically involves we understanding the waste items that we generate. On the nursing home generate ಮಾಡುವಂತ waste, it will be little different from what our veterinary colleagues will generate in their primary health centers or veterinary institutions. ಅದೇ ತರ ಆಯುಷ್ ಹಾಸ್ಪಿಟಲ್ಸ್ ಅಲ್ಲಿ what the kind of waste items that they generate will be little different from what we generate in the typical medical waste institutions. While all of them come under the biomedical waste rules, but the waste item, the character of the waste differs. So the first step in waste management is we understanding the character of the waste. And biomedical waste, whole of the biomedical waste categorization, color coding system is built on the character of the waste. Or whether it is a metal, whether it is a plastic, whether it is a liquid, whether it can be burnt safely. When I say burnt safely in the biomedical waste discussion, whenever we say burn, it means scientific burning, that is burning at very high temperatures, either using incinerators or other thermal technologies like pyrolysis. So burning the waste is scientifically, or whether it can be autoclaved to make it less, to reduce its infectious nature, whether it needs to be shredded. For example, plastics na ನಾವು ತುಂಡು ಮಾಡ್ತೀವಿ, it is called as shredding. We shred the plastics, medical plastics, so that it doesn't harm others. So all these things are a part of the management. Disposal is one final step in waste management. Now identify ಮಾಡಿ, categorize ಮಾಡಿ, color coded containers ಅಲ್ಲಿ contain ಮಾಡಿ, waste na safe ಆಗಿ store ಮಾಡಿ, then common biomedical waste treatment ಗೆ vehicle ಅವ್ರಿಗೆ hand over ಮಾಡಿ, ಅವರು ಒಂದು ಡೆಡಿಕೇಟೆಡ್ ವೆಹಿಕಲ್, ಆ ಡೆಡಿಕೇಟೆಡ್ ವೆಹಿಕಲ್ ಅಲ್ಲಿ ವೇಸ್ಟ್ ನ ತಗೊಂಡೋಗಿ ಇನ್ ದ ಕಾಮನ್ ಬಯೋಮೆಡಿಕಲ್ ವೇಸ್ಟ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಫೆಸಿಲಿಟಿನ ಯೆಲ್ಲೋ ಬ್ಯಾಗ್ಸ್ ನ ಇನ್ಸಿನರೇಟ್ ಮಾಡಿ, ಅದರಿಂದ ಬಂದಿರುವಂತ ಆಶ್ ನ ತಗೊಂಡು ಬ್ಲಾಕ್ ಬ್ಯಾಗ್ಸ್ ಹಾಕಿ ಹಜಾರ್ಡಸ್ ವೇಸ್ಟ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಫೆಸಿಲಿಟಿ ಕಳಿಸಿ ಅಲ್ಲಿ ಲ್ಯಾಂಡ್ ಫಿಲ್ ಮಾಡಿಸೋದೇ ಆಗಿರ್ಲಿ, ಅಥವಾ ರೆಡ್ ಕಂಟೈನರ್ ಅಲ್ಲಿ ಇರುವಂತಹ ಪ್ಲಾಸ್ಟಿಕ್ ಐಟಮ್ಸ್ ವಿಲ್ ಬಿ autoclave and it will be shredded, and the shredded ತುಂಡಾಗಿರುವಂತ ಪ್ಲಾಸ್ಟಿಕ್ಸ್ ನ ಪೊಲ್ಯೂಷನ್ ಕಂಟ್ರೋಲ್ ಬೋರ್ಡ್ ಆಥರೈಸ್ ಮಾಡಿರುವಂತ ಒಂದು ಪ್ಲಾಸ್ಟಿಕ್ ವೇರ್ ರಿಸೈಕಲ್ ಕೊಡೋದೇ ಆಗಲಿ. ಆಲ್ ದಿಸ್ ಥಿಂಗ್ಸ್ ಕಾನ್ಸ್ಟಿಟ್ಯೂಟ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್. Okay friends, so disposal is one final step. Please get this, please understand this point. So whenever we talk about biomedical waste, talk in terms of management. Now, ಈಗಾಗಲೇ ಹೇಳಿರುವಂಗೆ biomedical waste, any waste that we generate while taking care of the health of the human beings or animals, or during immunization sessions, or while conducting health camps, including research, all of that waste. So biomedical waste also applies to clinical research organizations, for example, and it applies to to a single doctor clinic to a large hospital. It applies to a small veterinary institution to a large veterinary university. It applies to a small Ayush practitioner to a large Ayush facility. It applies to everybody. And nobody is spared from the compulsions of authorization of the rules. We all have to take what you call the permission, or what we call as authorization from the Pollution Control Board for generation of biomedical waste. New clinic itkondra, you have to have an authorization from the Pollution Control Board. We need to seek that authorization. ನೀವು ವಿಲೇಜ್ ಅಲ್ಲೇ ಇರಲಿ, ಟ್ರೈಬಲ್ ಏರಿಯಾದಲ್ಲೇ ಇರಲಿ, ಹಿಲ್ಲಿ ಏರಿಯಾದಲ್ಲೇ ಇರಲಿ, ಅರ್ಬನ್ ಸ್ಲಮ್ಸ್ ಅಲ್ಲೇ ಇರಲಿ, ಎಲ್ಲೇ ಇರಲಿ. Now rules 2016 and amended rules applies to every healthcare institution, wherever it is located, whether it is a single doctor clinic or a large hospital. So few key definitions, I leave it to you all to read. It's self-explanatory. The only take-home message point from my side here from this slide is, we all are responsible. We all are liable. You cannot say I'm a nurse, my doctor is responsible for waste management. I am not under Hagal. Biomedical waste makes it clear, and it obligates the proper management of waste on everybody who are involved in its generation. So everybody is responsible, not just the head of the institution. Now, coming to the composition of the biomedical waste, you all know this. You have seen this slide before. Only 15% of the hospital waste is infectious, hazardous, little dangerous, and the rest of the waste is non-infectious. And our challenge is to see that we have to keep this infectious waste as infectious waste and non-infectious waste as non-infectious waste. And that will happen, like Dr. Prithvish mentioned, only when we change our attitude and when you bring the good aspects of your day-to-day practices to your hospital. Now, every household in India segregates the waste, be it in rural area or urban area or slum. Our milk packets we never throw away into a waste container just like that. We keep it separately in a separate bag. Newspapers na separate agirthivi. Why? Because at the end of a month or 2 months, you give it away to a recycler and you get money out of it. So we have that practice, we have that culture, which is good, but we have to bring that to workplace. We have to bring that to our work environment, which unfortunately is not happening even today in many places. So we have to bring that culture to work environment, and we have to segregate the waste as per the details I'm going to mention in my subsequent slides, so that we comply with the law and ensure that our hospital environments remain safe for the healthcare delivery. Sir ಹೇಳ್ದಂಗೆ ಏನೋ ಟ್ರೀಟ್ಮೆಂಟ್ ತೊಗೊಳಕ್ ಬಂದು ಇನ್ನೊಂದು ಯಾವುದೋ ಕಾಯಿಲೆ ತಗೊಂಡು ಹೋಗೋದು ಬೇಡ. And that happens if we do not manage our waste as per the requirements. Now, whenever we talk about biomedical waste, the discussion on biomedical waste is incomplete if we do not talk about general waste. The 85% chunk is general waste. And as per the solid waste management rules, we have to segregate the general waste as biodegradable waste, that is wet waste, or dry waste. These are the few examples I have mentioned here. So biomedical waste and solid waste management rules, go hand in hand. Now, to demystify biomedical waste rules, this slide, what you are seeing is a combination of the schedules in the biomedical waste, a schedule concerning the color codes, containers, and the related aspects. So this slide really is telling you the various color codes that we use for segregation of the waste in the hospitals. And it also has in the second row the color codes that are suggested for managing municipal solid waste, which the hospital generate. Now, yellow waste is for infectious solid waste such as cotton dressings, anatomical waste. All the waste in the yellow will go for scientific burning. Waste in the red containers is meant for plastics, only plastics, nothing but the plastics. The only exception is the blood bags. Blood bags will go into the yellow container. After getting autoclaved, they go into the yellow container. Adondu bitre ella plastics ತ್ಯಾಜ್ಯನು ಕೂಡ red container ಗೆ ಹೋಗಬೇಕು. Then we have the blue container, which is meant for glass and metal implants, and we have waste shop containers. Idina bidisi I will tell you in subsequent slides, but it's just to give you an idea as to what the color coding system is under the rules. And metal shop ke white translucent punch-proof container we have to use. And for municipal solid waste, you all know, for biodegradable waste we need to use green, and for other dry waste it is a light blue color we can use, as against the dark blue which we use for the glass and metal implants. Now, coming to the yellow container, friends, please kindly pay attention. Yellow antakshane, there are actually For example, in a medical college, there is a possibility that the hospital will have a yellow container for 3 different types of the waste, which all of which need to be burnt. ಉದಾಹರಣೆಗೆ ಒಂದು ಮೆಡಿಕಲ್ ಕಾಲೇಜ್ ತಗೊಂಡ್ರೆ ಮೆಡಿಕಲ್ ಕಾಲೇಜಲ್ಲಿ ಆಂಕಾಲಜಿ ವಿಂಗೂ ಇರುತ್ತೆ. ಸೊ ಆಂಕಾಲಜಿ ವಿಂಗ್ ಅಲ್ಲಿ ನಾವು ಸೈಟೋಟಾಕ್ಸಿಕ್ ಡ್ರಗ್ಸ್ ಯೂಸ್ ಮಾಡ್ತೀವಿ. ಲಾರ್ಜ್ ಹಾಸ್ಪಿಟಲ್ಸ್ ಅಲ್ಲಿ ಫಾರ್ಮಸಿ ಇರುತ್ತೆ. ಸೊ ಅಲ್ಲಿ ಎಕ್ಸ್ಪೈರ್ಡ್ ಡ್ರಗ್ಸ್ ಅಥವಾ ವಾರ್ಡ್ಸ್ ಇಂದ ರಿಟರ್ನ್ ಆಗಿರುವಂತ ಪಾರ್ಷಿಯಲಿ ಯೂಸ್ ಡ್ರಗ್ಸ್ ಎಲ್ಲ ಬರ್ತದೆ, which for some or the other reason we will not be able to send back to the wholesalers. And obviously the other waste in we generate in the hospitals is soil waste such as cotton dressing, sanitary napkins, human anatomical waste, tumor tissues, lab specimens ಇತ್ಯಾದಿ. ಇದೆಲ್ಲ ಕೂಡ ಎಲ್ಲೋ ಕಂಟೈನರ್ಗೆ ಹೋಗ್ಬೇಕು. ಅಂದ್ರೆ ಇದರ ಅರ್ಥ ಏನು? ಸೈಟೋಟಾಕ್ಸಿಕ್ ಡ್ರಗ್ಸ್, ಎಕ್ಸ್ಪೈರ್ಡ್ ಫಾರ್ಮಸ್ಯೂಟಿಕಲ್ಸ್, ಕಾಟನ್ ಡ್ರೆಸ್ಸಿಂಗ್ ಎಲ್ಲಾನು ಕೂಡ ಒಂದೇ ಎಲ್ಲೋ ಕಂಟೈನರ್ಗೆ ಹೋಗ್ಬೇಕಾ? ಇಲ್ಲ. ರೂಲ್ಸ್ ಆರ್ ವೆರಿ ಕ್ಲಿಯರ್. that's where I said, if we ಬಿಡಿಸಿ ನೋಡಿದ ರೂಲ್ಸ್, actually it is like it will act like a guidebook for us. So rules are very clear for these three streams of waste, all of which need to be contained in yellow container, and all of which will be sent for scientific burning, either by incineration or incineration by very industrial grade incinerators or by pyrolysis. Whatever may be the technology we use, but the prior requirement is first yellow container only. In the first yellow container, there can be only human anatomical waste, animal waste or soil waste, or biotechnology or microbiology specimens ಅಂತದ್ದು, ಕಲ್ಚರ್ ಮೀಡಿಯಾ. ಇದಷ್ಟೇ ಹೋಗ್ಬೇಕು ಬ್ಲಡ್ ಬ್ಯಾಗ್ ಜೊತೆಗೆ, ಇದಷ್ಟೇ ಹೋಗ್ಬೇಕು. ಇದರಲ್ಲಿ ಎನಿವೆ ನೀವು ಎಲ್ಲೋ ಕಲರ್ ಕೋಡ್ ಅಂತ ಹೇಳಿದ್ರಲ್ಲ, ನಾನು ಫಾರ್ಮಸ್ಯೂಟಿಕಲ್ ವೇಸ್ಟ್ ಇದರಲ್ಲಿ ಹಾಕ್ತೀನಿ ಅಂದ್ರೆ ಆಗ್ತದೆ. ನೋ, that is not permitted. This first yellow container is meant only for this. Second yellow container is meant for expired drugs and other partially used or discarded drugs. ಅದರಲ್ಲಿ ಬರೀ ಫಾರ್ಮಸ್ಯೂಟಿಕಲ್ ವೇಸ್ಟ್ ಹೋಗ್ಬೇಕು. And in the third container, it should have cytotoxic drug. ಒಂದು ಫೋಟೋಗ್ರಾಫ್ ಇದೆ, ನಾನು ತೋರಿಸ್ತೀನಿ. ಸೊ ಥರ್ಡ್ ಯೆಲ್ಲೋ ಕಂಟೈನರ್ ಅಲ್ಲಿ ಬರೀ ಸೈಟೋಟಾಕ್ಸಿಕ್ ಡ್ರಗ್ಸ್ ಹೋಗ್ಬೇಕು. ಅದರಲ್ಲಿ ನಾನು ಬ್ಲಡ್ ಬ್ಯಾಗ್ ಹಾಕ್ತೀನಿ, ಎಕ್ಸ್ಪೈರ್ಡ್ ಫಾರ್ಮಸಿ ಮೆಡಿಸಿನ್ಸ್ ಹಾಕ್ತೀನಿ, ಅಥವಾ ಕಾಟನ್ ಪ್ಲಸೆಂಟಾ ಎಲ್ಲ ಹಾಕ್ತೀನಿ ಅಂದ್ರೆ ಆಗುದು? ನೋ, it is separate. So 3 dedicated yellow containers, one for cotton dressing, sanitary napkins, human anatomical waste, then second container for pharmaceutical waste, and third container for cytotoxic or genotoxic drugs. So please keep this in your mind. So blood bags ನಾನು ಆಲ್ರೆಡಿ ಹೇಳಿದೀನಿ, ಕನ್ಫ್ಯೂಷನ್ ಬೇಡ. ಬ್ಲಡ್ ಬ್ಯಾಗ್ಸ್ ಹ್ಯಾವ್ ಟು ಬಿ ಆಟೋಕ್ಲೇವ್. ಆಟೋಕ್ಲೇವ್ ಆದ ತಕ್ಷಣ ಯೆಲ್ಲೋ ಬ್ಯಾಗ್ ಅಲ್ಲಿ ಹಾಕಿ ಅದನ್ನ ಇನ್ಸಿನರೇಷನ್ಗೆ ಕಳಿಸ್ಬೇಕು. ಇಟ್ ಕ್ಯಾನ್ ಗೋ ಅಲಾಂಗ್ ವಿತ್ ದ ಕಾಟನ್ ಡ್ರೆಸ್ಸಿಂಗ್, ಸ್ಯಾನಿಟರಿ ನ್ಯಾಪ್ಕಿನ್ಸ್. ಓ ಡಾಕ್ಟರ್, ಇದು ಪ್ಲಾಸ್ಟಿಕ್ ಅಲ್ವಾ, ನಾನು ರೆಡ್ ಅಲ್ಲಿ ಹಾಕ್ತೀನಿ ಅಂದ್ರೆ ಇಲ್ಲ. ಓನ್ಲಿ ಎಕ್ಸೆಪ್ಷನ್ ಈಸ್ ಫಾರ್ ಪ್ಲಾಸ್ಟಿಕ್ ಕಮಿಂಗ್ ಇನ್ ಟು ಯೆಲ್ಲೋ ಈಸ್ ದ ಬ್ಲಡ್ ಬ್ಯಾಗ್, ದಟ್ ಟು ಆಫ್ಟರ್ ಆಟೋಕ್ಲೇವಿಂಗ್. ಇದೊಂದು ದಯವಿಟ್ಟು ಗಮನದಲ್ಲಿ ಇಟ್ಕೊಳ್ಳಿ. Blood bags before getting into the yellow bag should be autoclaved. That is required as per the rules. And autoclaving is the best method. Chemicals use ಮಾಡಬಹುದು, but we don't recommend it because it generates lots of aerosols. Very clumsy procedure. Best is autoclave. And yellow container ali already ಹೇಳ್ದಂಗೆ microbiology and biotechnology waste also should go to yellow container from the labs. Second yellow container, this is a photograph just to clear your minds. Second yellow container should look something like this. It should have only pharmaceutical waste. ಯಾವುದೇ ರೂಪದಲ್ಲಿ ಇರಲಿ, ಎಕ್ಸ್ಪೈರ್ಡ್ ಡ್ರಗ್ ಅಥವಾ ಡಿಸ್ಕಾರ್ಡೆಡ್ ಡ್ರಗ್, ಡಬ್ಬದಲ್ಲೇ ಇರಲಿ, ಬಾಟಲ್ ಅಲ್ಲೇ ಇರಲಿ, ಪುಡಿಯಾಗೆ ಇರಲಿ, ಅಥವಾ ಬ್ಲಿಸ್ಟರ್ ಪ್ಯಾಕ್ ಅಲ್ಲೇ ಇರಲಿ, ಯಾವ ರೂಪದಲ್ಲಿ ಇದೆಯೋ ಅದೇ ರೂಪದಲ್ಲಿ ವಿತ್ ದ ಪ್ಯಾಕೇಜಿಂಗ್ ಯು ಕಂಟೈನ್ ಇಟ್. That is our job. Don't worry about how the common biomedical waste treatment facility is going to manage it. That is not our headache. That is their headache. And Pollution Control Board and the common biomedical waste treatment facilities with other industries, they collaborate and they have a system in place to manage it. Let's not be worried. Our instruction is clear. Segregate pharmaceutical waste in whatever the form it is. So let's just segregate it, like you have seen in the photograph. Now, like I mentioned, the third yellow container is for cytotoxic drugs. Cytotoxic drug ge onde ಒಂದು difference. It again is a yellow container only, but yellow color coded container. But the requirement is the waste container should have a C symbol, and it should have the polythene liner inside, along with the biohazard symbol, should also have a C symbol like you are seeing in the photograph. That's the only difference. Now, red color coded, I have already mentioned, is meant only for the plastics alone, but nothing but the plastics. No metals, no glass in red, because all the waste in the red will go for autoclaving and thereafter for shredding. And we can't shred metal, we can't shred glass. So ದಯವಿಟ್ಟು ಅಪ್ಪಿತಪ್ಪಿನೂ ಕೂಡ ಹಾಕೋಕ್ ಹೋಗ್ಬೇಡಿ ರೆಡ್ ಅಲ್ಲಿ glass or metal, please. It is meant only for plastics. Only exception is the blood bag, which will go into the yellow. That too after getting autoclaved. These are the few photographs just to convey to you the red color code system. And the blue color code is meant for containing the glass waste and the metal implants or the prosthetics, discarded or damaged prosthetic or metal or the implants. Idella hospitals generate agalla, only large institutions, trauma care, accident care hospitals generate agutte. But wherever it gets generated, the glass waste, broken ampules, slides, IV bottles should go into one dedicated separate blue color coded container, and the metal implants, prosthetic should go into the second dedicated blue color coded container. And these two color coded containers should be made of thick kg cardboard, corrugated kg cardboard, and I have photographs I will show you. So first container and second container is for what we call metal implants or damaged implants or prosthetics. So like yellow, where there are 3 streams of waste in which we contain, blue only there are 2 streams of waste and therefore 2 containers. So this is how a blue container should be. It should be made of thick kg cardboard container. Sumar jagadalli is available illa, it doesn't matter, you will get it soon. But in the interim, ನೀವು ಸಿಕ್ಕುವಂತ ಕೆಜಿ ಕಾರ್ಡ್ಬೋರ್ಡ್ ನ ತಗೊಂಡು ಡಬಲ್ ಕೆಜಿ ಕಾರ್ಡ್ಬೋರ್ಡ್ ಒಂದ್ರೊಳಗಡೆ ಇನ್ನೊಂದು ಹಾಕಿ ಡಬಲ್ ಲೈನರ್ಸ್ ಹಾಕಿ ಅದನ್ನ ಬ್ಲೂ ಕಲರ್ ಪೇಂಟ್ ಆದ್ರೂ ಮಾಡಿ, ಬ್ಲೂ ಕಲರ್ ಸ್ಕಾಚ್ ಟೇಪ್ ಆದ್ರೂ ಯೂಸ್ ಮಾಡಿ, ಅಂಡ್ ಬಯೋಹಜಾರ್ಡ್ ಸಿಂಬಲ್ ಲೇಬಲ್ ಮಾಡಿ, ಗ್ಲಾಸ್ ವೇಸ್ಟ್ ಅಥವಾ ಮೆಟಲ್ ಇಂಪ್ಲಾಂಟ್ಸ್ ಅಂತ ನೀವು ಲೇಬಲ್ ಹಾಕ್ಬಿಟ್ರೆ ಅದು ಇಟ್ ವಿಲ್ ಸರ್ವ್ ದ ಪರ್ಪಸ್ ಫಾರ್ ನೌ. ಬಟ್ ಇನ್ ಅನ್ ಐಡಿಯಲ್ ವರ್ಲ್ಡ್, this is how the blue container should be. ಈ ನನ್ನ ಬಲಗಡೆ ಈ ಫೋಟೋಗ್ರಾಫ್ ಅಲ್ಲಿ ಇದೆ ನೋಡಿ, ಅವ್ರಿಗೆ ಸಿಗ್ಲಿಲ್ಲ, ಡಬಲ್ ಕೆಜಿ ಕಾರ್ಡ್ಬೋರ್ಡ್ ಯೂಸ್ ಮಾಡಿದ್ದಾರೆ ಅಂಡ್ ಸ್ಕಾಚ್ ಟೇಪ್ ಹಾಕಿ ಇದು ಮಾಡಿದ್ದಾರೆ, ಅದಕ್ಕೊಂದು ಬಯೋಹಜಾರ್ಡ್ ಸಿಂಬಲ್ ಹಾಕಿ ಲೇಬಲಿಂಗ್ ಮಾಡಿದ್ರೆ ಇಟ್ ವಿಲ್ ಸರ್ವ್ ದ ಪರ್ಪಸ್ ಫಾರ್ ನೌ. Now the waste shop should be contained, metal waste shop should be contained in puncture proof containers, and the typical puncture proof container is seen in the photograph. But you can use any puncture proof container that is available with you in our hospital and start containing the metal sharps in it, including insulin syringes and preloaded heparin syringes. ಅದನ್ನು ಕೂಡ ವೇಸ್ಟ್ ಶಾರ್ಪ್ ಅಂತಾನೆ ನೀವು ಪರಿಗಣಿಸಿ ಅದನ್ನ ನೀವು ಆ ವೇಸ್ಟ್ ನ ನೀವು ವೇಸ್ಟ್ ಕಂಟೈನರ್ ಅಲ್ಲಿ ಪ್ಲಾಸ್ಟಿಕ್ ಪಂಚರ್ ಪ್ರೂಫ್ ಕಂಟೈನರ್ ಅಲ್ಲಿ ಅಲ್ಲಿ ಕಂಟೈನ್ ಮಾಡಿ ಪ್ಲೀಸ್. ಇಲ್ಲ ಸರ್, ನಾನು ಇನ್ಸುಲಿನ್ ಸಿರಿಂಜ್ ನಾನು ಕಟ್ ಮಾಡ್ತೀನಿ, ನೀಡಲ್ ಸಪರೇಟ್ ಮಾಡಿ ನೀಡಲ್ ನಾನು ಪಂಚರ್ ಪ್ರೂಫ್ ಕಂಟೈನರ್ ಹಾಕ್ಬಿಟ್ಟು ಪ್ಲಾಸ್ಟಿಕ್ಸ್ ನಾನು ಪ್ಲಾಸ್ಟಿಕ್ ವೇಸ್ಟ್ ಹಾಕ್ತೀನಿ ಅಂತ ಹೇಳಿದ್ರೆ, ರೆಡ್ ಕಂಟೈನರ್ ಹಾಕ್ತೀನಿ ಅಂದ್ರೆ ಮಾಡಬಹುದು, ಬಟ್ ಡೂ ಇಟ್ ಸೇಫ್ಲಿ. ದ ಹೋಲ್ ಪರ್ಪಸ್ ಆಫ್ ಬಯೋಮೆಡಿಕಲ್ ವೇಸ್ಟ್ ಈಸ್ ಟು ಸೇಫ್ ಗಾರ್ಡ್ ಯುವರ್ ಹೆಲ್ತ್. While doing it, you should not get injured. That's the whole purpose. So this is a photograph of a typical puncture proof container. It is for your idea. And the requirements for any container that we use in the biomedical waste is, it should be of good quality, it should be color coded, it should have a biohazard symbol, it should be labeled, and ideally it should be foot operated one, as against we requiring our hands to lift the lid. That no touch containers anta karitivalla, no touch containers idre better. And all the containers should have the same colored plastic liner, and in the plastic liner also should have a biohazard symbol. And for special waste such as cytotoxic drugs, along with the biohazard symbol, we must also have the cytotoxic symbol. the C symbol, which you have seen in the photograph. Now, the new introduction in the amended rules is the barcoding system. Earlier, we used to write on the polythene liners, name of the hospital, which ward, on which date, what is the quantity of the waste ಅಂತ ನಾವು ಪಾಲಿಥಿನ್ ಲೈನರ್ ಮೇಲೆ ಬರೀತಾ ಇದ್ವಿ. But now the rules make it mandatory for the hospitals to have a barcode system or a QPR code system in place. So these are the photograph to give you that idea, and that will tell. It is like it will tell us all the details. When you read that barcode, it will tell from which hospital it has come, what is the house, what is the category of the waste, what is the quantity, and what date it has been handed over to the common biomedical waste treatment facility. Anta all that is vertical bars alli adigide information. So instituting barcode system is also a mandated thing from the hospitals. But in the interim, ನಿಮ್ಮ ಅಕಸ್ಮಾತ್ barcode system ಇಲ್ಲ ಅಂತ ಹೇಳಿದ್ರೆ, ನೀವು whether we like it or not, on the plastic liner, you must use with a marker pen. You must mention which hospital it is, what is the waste that is there, what is its kilo, what is the quantity, and what date, and the person who is handing over that waste to the waste handlers. ಅದನ್ನು ಬರಿಬೇಕಾಗತ್ತೆ. Now, ನಾವೆಲ್ಲ ಸೆಗ್ರಿಗೇಟ್ ಮಾಡಿ ಸ್ಟೋರ್ ಮಾಡಿರುವಂತ ವೇಸ್ಟ್ ಇನ್ ಯೆಲ್ಲೋ, ರೆಡ್, ಬ್ಲೂ ಅಂಡ್ ಪ್ಲಾಸ್ಟಿಕ್ ಪಂಕ್ಚರ್ ಪ್ರೂಫ್ ಕಂಟೈನರ್ಸ್ ನ ಈ ತರ ಒಂದು ವೆಹಿಕಲ್, ಕಾಮನ್ ಬಯೋಮೆಡಿಕಲ್ ವೇಸ್ಟ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಫೆಸಿಲಿಟಿ ಇಂದ ಸ್ಪೆಷಲೈಸ್ಡ್ ಫ್ಯಾಬ್ರಿಕೇಟೆಡ್ ವೆಹಿಕಲ್ will come, and it will maintain the same stream of segregation and will take the waste from our hospitals to common biomedical waste treatment facility. And in the common biomedical waste treatment facility, the yellow waste will be incinerated or pyrolyzed, red will be autoclaved and shredded, and blue will be again autoclaved, and it will be handed over to a recycler. Then the waste shops also will be disinfected, either chemically, mostly chemically, or including autoclaves can also be used. And it will invariably, Prithvi sir ಹೇಳಿದಂಗೆ, recycling is not a great option there. Invariably, these metal shops will go for landfilling. But the people are trying to see whether these metal shops can be used for laying of the roads and for foundation ಅಲ್ಲಿ ಯೂಸ್ ಮಾಡಬಹುದು ಅಂತ ಸುಮಾರು ಎಕ್ಸ್ಪೆರಿಮೆಂಟ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. So, but our mandate, again, I keep saying this, is clear. Segregate the shops in puncture-proof container. Let's not worry about what is happening to it at a later point of time. And the places where there is no linkage to the common biomedical waste treatment facility, the rules made a provision that those kind of healthcare facilities with the prior permission of the Pollution Control Board can have their own waste shop pits and can have their own deburial pits. ಮಾಡ್ಕೋಬಹುದು ಅಂತ ಹೇಳುತ್ತೆ ರೂಲ್ಸ್. That provision is made in the rules, but that is only with the prior permission of the what do we call, the Pollution Control Board. Otherwise, it is expected that every healthcare institution is get linked up to the common biomedical waste treatment facility. ದಯವಿಟ್ಟು ಇದು ಮನಸ್ಸಲ್ಲಿ ಇಟ್ಕೊಳ್ಳಿ. This I've already mentioned. Liquid waste has always been a challenge in biomedical waste. Now, in small hospitals, Karnataka Health System Development Project has given a small manual as to what you can do to manage this waste. That will be shared with all of you. Most of you already have it. Adar takkange you can fabricate a liquid waste management system in your hospitals and manage the waste. But for other hospitals, having a effluent treatment plant is made mandatory in the new rules. So we have to have effluent treatment plants for managing the liquid waste. So these are the few examples from our own government hospitals as to what those hospitals have done to manage the liquid waste. And all this is based on the KHSDP's that manual on liquid waste management. Now, integral to the biomedical waste management system is biomedical waste management ಅಂದ ತಕ್ಷಣನೇ ಇದು ವೇಸ್ಟ್, ಕಲರ್ ಕೋಡಿಂಗು, ಬಾರ್ಕೋಡು, ಬಯೋಹಜಾರ್ಡ್ ಸಿಂಬಲ್ಸ್ ಅಲ್ಲ. Integral to this biomedical waste system is also the occupational safety of the health of the human beings who are handling this waste. It is integral to the biomedical waste rules. In the earlier avatars of the rule, it was not clear, but now in the latest amended rules, it's very, very clear. Annual health checkups and annual health checkup ಮಾಡಿರುವಂತ health file ನ record ನ ನಾವು ಇಟ್ಕೋಬೇಕು. ಪೊಲ್ಯೂಷನ್ ಕಂಟ್ರೋಲ್ ಬೋರ್ಡ್ ಎನ್ವಿರಾನ್ಮೆಂಟಲ್ ಆಫೀಸರ್ಸ್ ಬಂದಾಗ ಆಡಿಟ್ಗೆ ಅಥವಾ ಇನ್ಸ್ಪೆಕ್ಷನ್ ಬಂದಾಗ they may ask for it and you have to show. Now immunization is compulsory of the waste handlers. Please ensure that our waste handlers are immunized with tetanus and hepatitis, and training of healthcare personnel regularly and or periodic training programs like what is happening now also is required. Everything should be documented. ಯಾರಿಗೆ ಟ್ರೈನಿಂಗ್ ಆಗಿದೆ, ಯಾವ ದಿನ ಯಾರು ಬಂದ್ರು, along with the photographs, please document and make a small report and keep it for your inspections and audits. And we have to have records and registers for injury record for needle stick injuries and any other injury while handling the waste, and any accidents concerning biomedical waste, short circuit agli, fire accidents agirli, athwa ನಾವು waste na ತಗೊಂಡು ಹೋಗುವಾಗ ಟ್ರಾಲಿ ಟ್ರಿಪ್ ಆಗಿ ಅಥವಾ ಟರ್ನ್ ಆಗಿ ಬೀಳುದಾಗ್ಲಿ, ಎನಿಥಿಂಗ್ ಕನ್ಸರ್ನಿಂಗ್ related to biomedical waste handling, an accident should be recorded and kept in the files. Even that can be asked when inspections, during inspections and audits. And we have to have the waste management committee in the hospital, and the members of the committee should be notified to the pollution control board. Now annually, whenever we apply for while applying and also for annual renewal, we have to give all these documents. So we have to have a waste management committee, biomedical waste management committee, or HICC can also double up as a biomedical waste management committee. That's not a problem, but it must have biomedical waste takkange, it must have separate meeting records, and that meeting minutes of the meeting also should be kept. And this committee must be meeting regularly, and all along it should review the biomedical waste systems in the hospital, and it should identify problems and rectify those problems. That is the purpose of the meeting, these biomedical waste meetings. And other most important thing is, sir helidru, we do not have solutions for all the waste like the way we want it to be. Not everything can be recycled safely like the way we do with plastics. Glass ಹೇಳ್ತೀವಿ segregate ಮಾಡಿ plastic recycle ಮಾಡಬಹುದು ಅಂತ ಹೇಳ್ತೀವಿ ನಾವು, but that is a tough task. Again, like I said, you don't worry about it, let's not get worried about it, we segregate it and let's leave it to technologies and other higher authorities to manage it. But the point I'm trying to make here is, while we manage the waste, one aspect of waste management is waste minimization also. We must always think ಎಲ್ಲೆಲ್ಲಿ ನಾವು ವೇಸ್ಟ್ ನ ಜನರೇಟ್ ಮಾಡೋದು ಕಡಿಮೆ ಮಾಡಬಹುದು. That also is a part of our mandate. We have to keep that in our mind and see that we generate less of waste. So waste minimization is the key. And along with the biomedical waste rules, hospitals also have to comply with the e-waste management rules 2016, hazardous waste management rules also, and radioactive waste as per the Department of Atomic Energy, Baba Atomic Research Center guidelines. ಅನುಗುಣವಾಗಿ ನಾವು ಮ್ಯಾನೇಜ್ ಮಾಡಬೇಕಾಗುತ್ತೆ wherever we are generating the radioactive waste, which usually happens in large hospitals, oncology centers, ಎಲ್ಲ ಕಡೆ it must comply with the BARC guidelines. These are the biohazard. Few photographs I have, biohazard symbols. Biomedical waste management is for the purpose of occupational safety of our own people first. So occupational safety, along with the practices, few equipment also. These are the PAPEs. Either ಬಗ್ಗೆ details ella my other colleagues, Dr. Akshaya and Dr. Manjunath, will tell you the details. COVID waste first is much is talked about COVID waste, but let's not be unduly worried. COVID waste management principles are the same. Segregation is the same. Segregation norms are the same. Containment and color coding norms are the same. The only difference is we have to use double liners wherever you are using 0.1, 0.2, we have to label it. That my colleagues Akshaya and Manjunath will touch upon. I will not go into the details of it. The doctors will give you lot many details. But all I want to convey is principles are the same. So these are the few things again. And these are the key points for you all. The slides will be shared with you. You can use the slides for your training program as well. There are few points that we have put up here just to reinforce to you, so that you will find it easy when you use these slides for your training programs. So this is a photograph of a trolley. This is a dedicated biomedical waste area in a hospital. ಯಾವುದೊಂದು ಮೂಲೆಯಲ್ಲಿ ಕೊಡೋದಲ್ಲ, ಅದಕ್ಕೊಂದು ಡೆಡಿಕೇಟೆಡ್ ಇಂಜಿನಿಯರ್. ಇದಕ್ಕೂ ಕೂಡ in the 2016 rules there is a civil engineering detail as to how this biomedical waste area should be. So here is a typical biomedical waste area, dedicated place, well illuminated and safe and secured. So this is the weighment of the biomedical waste, and illi QPR code use agide, barcode or QPR code, whichever your vendor gives, you can use. So this will help us track the waste. So the purpose of barcoding is it will tell us which hospital, which ward, on what date, what is the quantity and what is the category of the waste. And when we do this weighments in the hospital, immediately this information goes into the website of the institution, and the pollution control board officials sitting here in headquarters can look at the click of the button. They will know what is the amount of waste Narayana Hrudaya or MS Ramaya Hospital or KIMS Hospital has generated. So these are the few photographs concerning the barcode system. A storage area, hospital ಅಲ್ಲಿ wards ಅಲ್ಲಿ ಯಾವ ತರ segregate ಮಾಡಿದ್ರು ಅದೇ ತರ segregation is maintained in this final storage area, and vehicle will take the waste as such in the same way to the common biomedical waste treatment facility. This is a photograph of a waste shark pit for hospitals which do not have a linkage. This is a photograph of a deep burial pit. The point here is these hospitals have to take a special permission from the pollution control code. Now, and like I said, and repeating again, discussion of biomedical waste is incomplete if we do not talk about general solid waste. So compliance with the solid waste management rules 2016 for management of general waste also applies to the hospital. So we have to manage the waste accordingly. So I come to the end of my presentation, friends. These are the resources I've used for this presentation. So I acknowledge all these sources. So thank you all very much. Thank you all very much.
Participants, if you have any queries or questions, you can ask now. Unless you can drop your question or queries on your chat box, we can
we'll
take
answer
it over on the end of the session.
And madam, please share the email ID, so that they can also email us the questions.
We'll do, sir.
Okay, ನೀವು ಪುನಃ ಎಲ್ಲ ನಮ್ಮ ದಕ್ಷಿಣ ಕನ್ನಡ ಜಿಲ್ಲೆಯ ಆರೋಗ್ಯ ಸಿಬ್ಬಂದಿ ವರ್ಗದವರಿಗೆ ನಮಸ್ಕಾರ.
Thank you so much, Dr. B. Ramakrishna Gaur, sir, for detailed explanation about segregation of biomedical waste. Now I would like to welcome the resource person for the next session on gap analysis, biomedical waste management by Dr. Akshaya KM, sir, Additional Professor, Community Medicine, Mangaluru. Over to you, sir.
Thanks, Pooja. Am I audible?
Yes, sir, it's audible, sir.
Okay.
You're audible, Akshaya.
Yeah, thanks. Thanks, sir. Yes, could you appreciate the movement of the slide? Yeah, could you appreciate the movement of the slide?
Yes, sir. Yes.
Yes. Okay. Pooja, request you to mute the other participants because there has been a lot of background noise.
Yes, sir. We are doing, sir.
Okay. Okay. Thanks, Empri, for having given me this particular opportunity where I would be talking to you, talking to the participants on gap analysis in biomedical waste management over the next 20-25 minutes. And then we can have a small discussion wherever required. So this particular topic focuses mainly on what are the issues or challenges and where are the gaps as far as efficient or quality biomedical waste management is concerned. So we think that all of us are doing well, and we have been quite efficient in management of biomedical waste at our own levels, whether it is an administrator or whether it is a floor manager or whether it is a HICC nurse or nursing superintendent or nursing supervisor, or even the person who is carrying or lifting up this particular biomedical waste. But when biomedical waste practices were assessed, were actually looked into in certain parts of India as well as Karnataka, there were some issues or gaps which were found by various studies. So we'll discuss some issues about this in the next few minutes. So my presentation will focus on what is the biomedical waste management scenario in India as well as Karnataka. And our Central Pollution Control Board has laid out certain performance indicators to assess the biomedical waste management at the state as well as the district level. So we'll go through those indicators because these indicators will help, especially when we are devising our own mechanisms to improve the HCWM at our own institutions. Then we'll see what are the gaps or where are we faltering at as far as the healthcare waste healthcare facility level is concerned, and then gaps at the level of the common biomedical waste treatment facilities. And there are some solutions and how we can plug these particular gaps. So that will be the last part of the presentation. So even biomedical waste scenario, if we see across India, we have around 3.25 lakh healthcare facilities, and of this, only 1/3 or around 30 odd percent are bedded healthcare facilities, and there are 2 lakhs odd which are non-bedded. That means these non-bedded are actually single operated, single doctor operated clinic, or we have certain polyclinics where there are no beds for the patient. So we have around 25 lakh beds across India, and the number of common biomedical waste treatment facilities as of 2019 were around 202, which were in operation, and around 35 were under installation. However, of these around 3 lakh 25,000 healthcare facilities, only 50% of them have been given authorization or granted authorization by the CPCB. There are some healthcare facilities which have got captive treatment facilities. That means they have treatment facilities for healthcare waste within their campuses or within their setups. However, this is to be done with permission from the state pollution control boards and pollution control board offices which are there at the district level. And there are around 136 captive incinerators which have been managed by healthcare facilities. See, this is what we are actually worried about. We generate around 619 tons of biomedical waste per day. This is pre-COVID scenario, and this has increased by 100 to 200 tons more during the time of peaks of COVID waves. Whereas of this, we are able to treat only around 540. That means around 10 to 15% of our biomedical waste goes untreated. So that's a worrying figure actually. And if we see the number of healthcare facilities who have violated the biomedical waste management rules, they are 29,000. So this is actually, we can say this is a tip of the iceberg because there have been many more violations. And of them, 17,000 odd have been given show cause notices by the pollution control boards. This particular data, whichever I have shared with you over, in the last 2 slides, they're all available in the public domain from pollution control board website. So there is no secrecy in this. It's all available from the website. And if we see where are the gaps mostly observed, we have states of Assam, Bihar, Chhattisgarh, Jammu Kashmir, including Karnataka, Kerala, Maharashtra, Madhya Pradesh, and some of the northeastern states. where gap in generation and treatment of this biomedical waste being observed. Of the states, 35 odd states, we have around 28 states which have environmentally safe disposal mechanisms for biomedical waste management. There are some states which are very small states like Goa, Andaman Nicobar, Arunachal Pradesh, and some northeastern states who don't have their common biomedical waste treatment facilities. So these are the states where there are some captive facilities which are operating, or the healthcare waste is being managed in other scientific ways. As far as the state of Karnataka is concerned, we have around 27 biomedical waste common treatment facilities, and we generate around 77 tons per day. This is pre-COVID scenario I am talking about. And then we can see only half of it is actually scientifically treated. If we see the capacity, what we are utilizing, actually we are utilizing only 33% of the authorized capacity of this biomedical waste treatment facilities, which is quite low or suboptimal. And violations have been around 4,000 and less than 1,000 have been issued show cause notices. So you can see that there are gaps between generation and treatment. There have been gaps between the violations as well as the notices which have been served. Then comes the pandemic of COVID-19. So where we see around 23 tons per day of this COVID waste is being produced and which has been documented over the COVID-19 biomedical waste tracking app. So much more would have been produced, but this is what is documented on this particular app. And 196 out of 202 biomedical waste treatment facilities have started using the tracking app. And that is some encouraging figure because the gap over here is very, very less. As far as Karnataka is concerned, we are generating around 1.1 tons per day, and around 10 CBWTFs are engaged as far as managing this COVID-19 biomedical waste is concerned. So these are recent figures from 2021 December, just before the third wave. So coming to what are being used, what are the indicators or the performance indicators used by Pollution Control Board and also the state pollution control boards for assessing the management of healthcare waste. So they do inventories of all healthcare facilities and biomedical waste generation. Then they also bring out how many healthcare facilities are being authorized out of the existing one, because that's also an operational indicator that how well they are doing as far as authorization is concerned. Then they facilitate setting up of adequate number of CBWTFs to cover the entire state or all facilities. So ideally a CBWTF should be able to cover within 75 kilometers of its radius all the healthcare facilities which are existing. So in exceptional circumstances, it can go up to even 150 kilometers. And there is a constitution of state advisory monitoring committee as well as district level monitoring committee. Then how far have we implemented the barcoding system? Because this will help us to identify which are the places from where the waste is coming to the central facility. And monitoring of hospitals or clinics which are other than the healthcare facilities or allopathic system of medicine, such as veterinary hospitals, animal houses, or Ayush hospitals, where also we can see that healthcare waste is being generated. Then how is the infrastructure of SPCBs and pollution control committees being monitored? What is the level of training and capacity building of the officials and of SPCBs, PCCs, and healthcare facilities? This next indicator is particularly applicable to the common biomedical waste treatment facilities, that whether there has been an online monitoring system of the emissions and effluents which are coming out of the biomedical waste treatment facilities once this biomedical waste is being treated. Then preparation of annual compliance status reports. So all these indicators are being monitored, and there needs to be a annual report which needs to be submitted from the state to the CPCB by July end. So how many of the states are complying with this? Last two are compliance by the health facilities as well as the common facilities when it comes to certain other performance indicators. So there are around 12 performance indicators which have been laid down by CPCB for monitoring. So if we see the components of waste management system, we can clearly identify gaps in various components, right from the segregation or even before that, where there are policies and SOPs, till its final treatment and disposal. So the gaps which have been identified are at the healthcare facilities level, at the level of the common treatment facilities, and at the level of the administration. So in the healthcare facilities, we can observe some gaps at the administrative level where some of the administrators themselves are not aware of what can be the issues associated with biomedical waste management, right from its segregation till disposal. And there may not be SOPs, there may not be the required infrastructure. So these are all the either knowledge, attitude, or implementation gaps at the admin level. But this is very difficult to see, especially in some of the very you can say districts which have got good health infrastructure like Dakshin Kannada, or even some of the districts which have got good human development index in state of Karnataka. But the next one is quite worrisome. Most of our healthcare workers do have a good knowledge. They may have a good attitude also, but there are gaps observed in practice, because most of the times doctors or other healthcare providers who are up the hierarchy of practice or healthcare practice do always think that it is not their job. It is the job of the nurses or ANMs or other subordinate staff to manage. But as we all know, segregation kind mute yourself. It disturbs a lot when the session is going to the other as well as to the speaker. So kindly mute. Request everyone to mute their mics. Yes, there can be gaps in practice which can be seen at various cadres, because most of us always think that it is the work of the nurses or our subordinate staff to efficiently manage the healthcare waste. But that's not the case, because we ourselves are also responsible, because we tend to generate the waste, and segregation at source is the key. And yes, right from an intern or a junior doctor or to the senior most consultant, it is required that what waste goes into which colored bin or which colored polythene bag. So that's very, very important, because once it goes to the wrong bin or the wrong polythene cover, so the problem starts from there. So this was a study which was conducted across 31 healthcare facilities in Karnataka during 2017-18. It was a part of a large UNIDO project which was implemented from the state of MS Ramaya, and we could see that they had divided the areas which need to be looked into few macro areas, right from whether there has been an existence of a committee which looks into this, whether there have been written SOPs, whether there is a designated temporary storage room, whether the workers were supplied with PPE, whether there was a waste management register, whether there was an injury register or and a spill register. So there were gaps observed, and the gaps were more so in the last component of maintaining a spill register. And there were also gaps in the first one or two, especially when it comes to the small healthcare facilities. So these points can be used by the administrators themselves to actually look into what is the status of the biomedical waste in their own facilities. And if they are not there, so kindly take actions in this particular regard to set them right, because once we are able to set right our systems, our own houses, then we can actually think of doing it for others. So this is what has come out from this particular study. Again, the same study also showed that the segregation efficiency was quite good, but there is a scope for improvement. However, it's not reflected in some of the recent studies which have been come up in this particular area. So this is more representative, where the study said that only 28% of the hospitals segregate the biomedical waste properly. That means what has to go into yellow bag goes into yellow, what has to go into red goes into red. So this is what was looked into, and 40% of its biomedical waste is not being treated as per the regional guidelines. So something which shouldn't be incinerated was going into incineration. Again, here the whole problem is associated with segregation. If we are not segregating it right in a right manner, then you tend to see that what shouldn't be incinerated goes into incineration. Some commonly observed violations. So these are pictures which show what can be the violations. So mixing up of biomedical waste with general waste. So again, you are converting that 85% of the general waste into 100% of biomedical waste in the process. Mismatch in color coded liners and containers. So there should have been a yellow bin with a yellow cover, which is not existing on in the left picture. So similarly, the color coded bins are not matching with the liners which have been used. So this is one of the common observations which was found in study. Then poor segregation. You can see that there is a carton, there is plastic, there is even a PPE sort of a thing in this particular yellow colored bag, which shouldn't have been. So you are putting the general solid waste, you are putting plastics, you are putting even some of the other things which shouldn't have been come over here. Again, a common observation, please you don't use the dressing trolleys for segregation of. You are trying to, you are in the process, you are also affecting other things that are there on this particular trolley, including the stationery and as well as whatever other medicines are also kept. So please see to it that once the waste is being generated, it goes into the designated colored bins, which are being kept in a designated place of the nursing station or in the ward. Improper transportation of biomedical waste, where you see that the trolleys, even though they have wheels, they tend to be overloaded in one, and the other one, there is no cover. And you can appreciate that the person who is transporting this trolley is not having any sort of personal protective equipment. So this is also a common observation. The right method is being put up on the right side of the slide. Even within the hospital premises, please use closed containers. Yeah, a picture of a place where biomedical waste is being stored. We usually say that there shouldn't be access to animals. It should be closed. It should be stored in a closed space, very well ventilated, with a proper roof. So in places with heavy rains, if there is no adequate roofing, you can see that there is flooding of the biomedical waste, which is being segregated and kept. So, and also animals do have access. So these are all the gaps which have been observed from various studies across Karnataka. Yeah, just a good practice which can be followed even by the people who are generating waste in small quantities. Let it be let it be a polyclinic or non-bedded healthcare facility where a plastic container with well ventilated lid and lock can be used for temporary storage of waste, maybe up to 48 hours or for 24 to 48 hours period. This is another issue which was being observed: handing over of biomedical waste to unauthorized waste handlers. So in the process, what can happen is that the syringes especially can come back to the system by the process of repacking, because most of these particular syringes, when they are not uh, when they are not disfigured, then there is a high possibility of that. So the list of authorized waste handlers who are there to take this particular waste is available with KSPCB as well as the district pollution control officials. So they can be contacted and you can get the list from them that who needs to be handed over these particular uh, biomedical waste, especially which can be recycled. Please don't go for open burning of any of these particular biomedical waste, because open burning of plastics as well as other biomedical waste can lead to emission of dioxins and furans. So again, very big or important contaminant which can lead to global warming or other sorts of pollution, issues related to pollution. And then, yes, mixing of general and healthcare waste, you can see that animals tend to feed on this, and again, this can be a problem in the long run, both for the animals as well as for the food chain. Yeah, as far as the status report of 2021 May is concerned, almost all states, with exception of Andhra, Arunachal Pradesh, Sikkim, and West Bengal, have organized training and awareness in the initiatives. So one such is also which we are conducting from EMPRI. So this particular one or two slides will focus on what are the common issues or gaps observed in the CBWTFs. So there can be concerns with online monitoring systems. So, however, we have online monitoring systems of all common biomedical waste treatment facilities of all 27. However, there is some gap which has been observed in barcoding implementation. So, this is on fast tracking mode. The process is in place. However, we have not done this across all the districts. So yes, in Dakshin Kannada, we have been quite successful in implementing this in many of the hospitals, but not all have really done this across the state. If the CBWTFs are not complying to the standards, especially when it comes to the temperature which needs to be maintained, World Health Organization says we need to maintain a temperature of 1200 centigrade in order to ensure that there is uh, clear incineration, and thereby in the process we tend to get gray colored ash. But once we have some black ash as well as unburnt components, we can see that these CBWTFs are not maintaining the or complying with the standards. One more concern: incineration of unsegregated waste, again, which can be a matter of concern, and that's not the standard which CBWTFs have to comply with. Some issues concerned with regulatory mechanisms. Monitoring of small and large healthcare facilities, again, is not happening to the fullest extent. So with the advent of COVID-19 and testing kits, we have a concern regarding the household biomedical waste, especially the COVID testing kits. So there have been videos in the recent past which have circulated on this, and the waste handler requesting the producers to ensure that please put a cross mark and mention it as hazardous waste, and it should not be going into either wet or dry waste. So following that, there was also a circular from Government of Karnataka to see to it that household biomedical waste needs to be handed over to the waste handler in an appropriate way. So a study from Karnataka again pointed out some gaps. It's a 2021 study which says that there is no regular monitoring of healthcare facilities. So we are not actually up to date as far as submission of annual reports are concerned. Then barcoding systems are not fully implemented. Then CBMWTFs need to be upgraded with new emission rules, and also authorization under BMW management rules is still lacking. So we have seen a lot of gaps, even though we thought that we are doing pretty well. But at that particular stage, if we think of only gaps and leave it, then the gaps will be left as gaps. So what can be some of the pragmatic solutions to plug these particular gaps? So one is, it has been time and again told that there should be some monitoring at the district level. The decentralization need to happen in a more better manner, and there should be monitoring at the district level regarding how this biomedical waste management is happening. So training and retraining, yes, we all know BMW rules of 2016, the amendments which have happened, but we all failed to actually implement that in a better or in an efficient way. So training and retraining. Third party audits. So wherever possible, if it is a government health system, or if it is a private health system, we can look for people from third party organizations who can come, who can audit what we are doing, and also suggest the corrective measures or the points where we can improve upon, because always third party audits are being taken in a better sense by the managements, whether it is private or government. Then we can have better accountability of the stakeholders, right from whether it is healthcare facilities or biomedical waste treatment facilities or the regulatory authorities. There should be budgeting for there should be budgeting for healthcare facilities within the system, whether it's government or private. Yes, in private we usually have it, but as far as the government is concerned, we tend to rely upon some of the untied funds which are available at the primary health center level or even taluka hospital level. So we need to look into this, how there can be a free flow of budget to ensure there is proper management of healthcare waste. Then this is the barcoding which I already told that it needs to be implemented in a fast tracking mode, covering across all the districts of Karnataka. Create or improve. So if it's not there, we need to create. If it is already there, then we need to improve the awareness with respect to source segregation of biomedical waste. And all waste generators and processors should be registered by the regulatory authorities on COVID-19 waste generation. Then installation and monitoring of the online systems for emissions at CBWTFs, extensive training and awareness programs for healthcare workers, then stringent methods to impose environmental compensation charge. So more upon this has been dealt in the National Green Tribunal, which has focused on environmental compensation charge, especially by the defaulters at the state and the district level, wherever there have been some improper healthcare waste management. And these are my references. So we touched upon what are the gaps at the healthcare facility level. We have touched upon what are the gaps at the CBWTFs level, and also at the administrative levels. We have looked in what is the current status of biomedical waste across Karnataka, and also what are the indicators which are being used to monitor the biomedical waste management. So that's in nutshell what I have covered over the last 20-25 minutes. So if there are any questions or concerns, we are in a position to take at this point of time. So thanks, Empri team. Any other points?
Thank you very much, Dr. Akshay sir, for the detailed deliberation on common mistakes made during segregation of waste at source and effective way to overcome this problem. Thank you so much, sir.
Just a minute. There are some
Queries are there.
queries. Yeah, sir is there. Ramakrishna Gaud sir is there.
ಇದೀನಿ ಅಕ್ಷಯ್.
Sir. Sir, can you take those queries which have been put up in the chat box? Shall I read it for you?
If you don't mind.
Okay, sir. Vacutainers with blood to be discarded in yellow or red biomedical waste container is one question.
Red. After autoclaving, red.
Okay.
After
spot on.
autoclaving, red.
So, yes. And if blood bags are having clotted blood, whether we have to discard the blood and send back for autoclave?
No, autoclave directly and no further handling of blood bag.
Okay.
Yadavidi adana autoclave ga hakbiಟ್ಟು put it into the yellow and give it to the biomedical common treatment facility.
Okay, sir. One question, no, where to put copper tea, which is
copper tea.
One of the questions from
the same question which you asked in the last session can be asked. Does it have metal part? Copper tea,
Hello,
is
sir.
it full
Yes.
metal or full plastic?
It can have both, no, sir. So
no, the participant who was asked can
Shanti Priya ma'am, are you there? Can you unmute
yes,
yourself?
Yes, cut having metal part. Somebody has answered that. Metal part, sir.
Aste. Like the way we have discussed for the what do you call this heparin syringes and insulin syringes. They come with preloaded medication, alva.
Howdu, sir?
So needle, what we call as needle embedded systems. ಆ ನೀಡಲ್ ನಾವು ಸಪರೇಟ್ ಮಾಡಕ್ಕಾದ್ರೆ ನೀಡಲ್ ನ ಸಪರೇಟ್ ಮಾಡಿ ಸಿರಿಂಜ್ ನ ಸಪರೇಟ್ ಹಾಕೋ ಅಂತ ಹೇಳ್ತೀವಲ್ಲ, ದ ಸೇಮ್ ಪ್ರಿನ್ಸಿಪಲ್ ಹೋಲ್ಡ್ಸ್ ಹಿಯರ್. ಇಫ್ ಯು ಕ್ಯಾನ್ ಸೇಫ್ಲಿ ಸಪರೇಟ್ ದ ಮೆಟಲ್, ಕಟ್ ದ ಮೆಟಲ್ ಫ್ರಮ್ ದ ಪ್ಲಾಸ್ಟಿಕ್, ಪುಟ್ ದ ಮೆಟಲ್ ಇಂಟು ದ ಇಟ್ ಕ್ಯಾನ್ ಗೋ ಇಂಟು ದ ವೇಸ್ಟ್ ಶಾಪ್ ಕಂಟೈನರ್ PPE and the plastic can go into the red container.
Okay. So any other questions? Sir, the thing is metal part would be wound around the plastic tea.
No, for simple, if you can't separate the metal from the plastic, then you disinfect and put it along with the blue container meant for metal waste, prosthetics anta ಹೇಳಿದಿವಲ್ಲ, metal implant prosthetics ಅದ್ರಲ್ಲಿ ಹಾಕಬಹುದು.
Okay.
ಯಾವುದೇ ಕಾರಣಕ್ಕೂ the summary of the story here is no metal or plastic or glass can go into the yellow except the blood bag. Similarly, no metal, no glass can go into the red container. ಇದನ್ನ ನೀವು ಮನಸ್ಸಲ್ಲಿ ಇಟ್ಕೊಂಡ್ರೆ many other things will fall into place.
Yes, sir, there is a question of how to get the barcoding system. Pooja, can you just highlight upon this? How to get about the barcoding system?
Akshaya, am I troubling you, making you read the questions?
Sir. No. It's my pleasure.
Okay. Thank you. It is helping me, Akshaya, you reading.
And this program I had taken long time. Nothing serious, but we have to obey government.
Okay. So, ನಾನು ಕ್ವಶನ್ ತಗೊಂತೀನಿ. ಸಾರಿ, ನಾನು ಅದು ಯಾವ ಕ್ವಶನ್ ಕೇಳಿದ್ರಿ, we didn't answer.
Sir, how to get barcoding system we need to implement in our hospital.
Correct. ಸೊ ಬಾರ್ಕೋಡ್ಗೆ ಅದಕ್ಕೆ ಸಪರೇಟ್ ವೆಂಡರ್ಸ್ ಇದ್ದಾರೆ. I can Codeland, for example, is a vendor that St. John's we have. So ಅದಕ್ಕೆ Pollution Control Board authorized vendors ಇದ್ದಾರೆ. So my suggestion is you can get in touch with your local environmental officer, or from EMPRI we can give you the names of these barcode vendors. We can give.
Okay. Yes. Radha madam, please message this. Please send this email. Email anna kaliskodi EMPRI email ID ge. So they will help you out in getting these particular vendors. ಅಥವಾ ಲೋಕಲ್ ಪೊಲ್ಯೂಷನ್ ಕಂಟ್ರೋಲ್ ಬೋರ್ಡ್ ನಮ್ಮ ಬೈಕಂಪಾಡಿ ಏರಿಯಾದಲ್ಲಿರೋ ಪೊಲ್ಯೂಷನ್ ಕಂಟ್ರೋಲ್ ಬೋರ್ಡ್ ಆಫೀಸ್ ಅಲ್ಲಿ ನೀವು ಕಾಂಟ್ಯಾಕ್ಟ್ ಮಾಡಿದ್ರೆ ದೇ ವಿಲ್ ಬಿ ಏಬಲ್ ಟು ಗೆಟ್ ಯು ದ ಡೀಟೇಲ್ಸ್ ಆಫ್ ಹೂ ಆರ್ ದ ವೆಂಡರ್ಸ್ ಹೂ ಕ್ಯಾನ್ ಹೆಲ್ಪ್ ಯು ಔಟ್ ವಿತ್ ದಿಸ್ ಬಾರ್ ಕೋಡಿಂಗ್ ಸಿಸ್ಟಮ್. ಸೊ ಹೋಪ್ ವಿ ಹ್ಯಾವ್ ಮೇಡ್ ಕ್ಲಿಯರ್.
Correct. Actually, what you said is on the hitting the nail on the head. Local environment office or pollution control board office is the source of information. Bondu. Yernedu, just to building on Akshay's answer, why we are saying pollution control board is biomedical waste takkange ella barcode vendors yaru idaro, they all have come through the pollution control board only. So that's why we are saying. Please, that's the reason why we are saying. Having said this, if the email is dropped, we can also share the few vendors whom we know.
Okay, sir. Couple of more questions. How to dispose the old X-ray films?
Yes.
Okay. See, old X-ray films now, it's plastic. If from a medical record perspective, if you no longer need it, those things can be considered as plastic. You can send it to plastic. But I would suggest before you do that, I suggest if you are in a medical college, please consult with your engineering and facility management, because it may have to go to the hazardous, as per the hazardous waste treatment facility. Hazardous waste management rules ಹೋಗ್ಬೇಕಾಗುತ್ತೆ. Okay, who has asked this question? Where is this question from?
This is from Mrs. Jyoti Manjunath. I don't know from which institution it is.
Okay.
So,
okay. If it is from a medical college, if madam is from a medical college, then or a large hospital such as district hospital, then engineering and facilities management people will guide. But if they are from a small hospital and ಹೇಳಿದ್ರೆ, then we will do one thing. I can write a small SOP and share it with our participants for management of X-ray films at health facilities which do not have.
So I'm working in a community health center, sir. So
madam,
it would be helpful if you kindly share it, sir.
How do madam? We'll tell you. For us,
you.
those of us who are in large hospitals, our engineering and facilities management department, they take care of it. Mercury Jatage, this also they handle. But we will write up, ma'am. We will send you the details. New ದಯವಿಟ್ಟು ನಮ್ಮ EMPRI training team ಅವರಿಗೆ share your email and we will give you a solution, ma'am.
Yes, sir. Thank you, sir.
Yes, ma'am.
Sir, should we disinfect the PPC box? What is this PPC box? I'm not getting.
Puncture-proof container, huh?
What does PPC stand for? Puncture-proof container box. Okay. Should we disinfect the puncture-proof container box before giving it to common treatment facility?
Illa, puncture-proof container with metal sharp need not be autoclaved. But from an occupational and safety point of view, we recommend that you chemically disinfect it. Now, bleach solution use ಮಾಡ್ಕೊಂಡು, you disinfect with the needles with bleach solution. Just before you hand over, just overnight you can soak them in the bleach solution, decant it, and just the container can be handed over to common biomedical waste treatment facility. ಇದು ಸ್ವಲ್ಪ ನಮಗೆ ಕೆಲಸ ಆಗ್ತದೆ, ಬಟ್ ನೀವು ಮಾಡಲೇಬೇಕು. ಯಾಕಂದ್ರೆ if we do this, then we are protecting the waste handlers in the common biomedical waste treatment facility.
Okay, sir, what to do with the residual blood in vacuutiners?
No, it shouldn't be further handled. If the vacuutiner is having the blood ಅಂತ ಹೇಳಿದ್ರೆ, ಅದನ್ನ it has to be autoclaved, and it has to be if it is a plastic, it will go with the with our in the red container. all the vacuum containers are fiber plastic only nowadays. It will go with the red container. No further handling, no removing the blood and all that. No, it has to be autoclaved and it will go into the red container.
Yeah, can we use QR coding systems to label our bags? Not
Yeah, new madlebeku. That's what the new rules are all about. 2016 amended rules make it compulsory that everybody, all the waste categories must go out. Any bag that is going out of your hospital should have a barcode or a QPR code. No bag can go out of our hospital with a barcode or a QPR code. ಅಕಸ್ಮಾತ್ ನಿಮ್ಮ ಹಾಸ್ಪಿಟಲ್ ಅಲ್ಲಿ ಬಾರ್ಕೋಡ್ ಅಂಡ್ QPR ಕೋಡ್ ಸಿಸ್ಟಮ್ ಇರದೇ ಇದ್ರೆ ಆ ಸಮಕ್ಷದಲ್ಲಿ ನೀವು ಆ ಪ್ಲಾಸ್ಟಿಕ್ ಕಂಟೈನರ್ ಮೇಲೆ ನೀವು ಅದು ವೇಸ್ಟ್ ಕಂಟೈನರ್ ಒಳಗಡೆ ಹಾಕಕ್ಕಿಂತ ಮುಂಚೆನೆ ನೀವು ಅದನ್ನ ಮಾರ್ಕರ್ ಪೆನ್ ಅಲ್ಲಿ ಬರ್ದ್ಬಿಟ್ಟು ಆ ಬಾಡಿ ಕಾಲ್ ಆ ಪ್ಲಾಸ್ಟಿಕ್ ಲೈನರ್ ನ ವೇಸ್ಟ್ ಕಂಟೈನರ್ ಒಳಗಡೆ ಆಗಿ ತೆಗೆಯುವಾಗ you can tag it, weight and send it.
Okay.
The point here is the bag should have where it is coming from, which ward it has come from, what is the date, and who is the person who is handing over this waste. Our detail, basically the essence of barcode is this. Our barcode is there, e details you kayal baribekagtade.
Yes, the next question is also similar to that. What happened? I mean, whether barcoding is necessary for only the expired medicine, which with respect to Ayush doctors, which happens once in a while.
Even if it is 1 ampule, if you are sending it as a waste, it has to go in the yellow container with a barcode. Athwa nam Ayush medicine doctors from, if I have to take an example from that side, if it is one small 100 ml bottle of one our traditional medicine, it has to go in a yellow bag with a barcode.
Okay, sir, there are a couple of more questions. So is it necessary to keep the hub cutter in the current scenario?
No, again, see, waste sharp must be segregated. It is left to the institution. If you are using a hub cutter to cut the needle, then the needle will go into the waste sharp container. The syringe will go into the plastic container. Illa sir, now sir, separate madalla, we cannot cut the needle ant helidre. In that situation, all of the syringe should go as a waste sharp container, into the waste sharp container. But please understand, if the needle can be separated from the syringe, which most often we can. With 2 fingers, we mount the needle onto the nozzle of the syringe. That needles, we have to, it's good practice to segregate that needle and put it. You don't have to hub cut it. You don't have to cut the needle. You don't have to cut, burn anything. But needle should go into the puncture-proof container, and syringe as such can go into the red bag. You don't have to disfigure. The point is, you don't have to disfigure at your level.
Where we need to put the removed IUCD or copper T, again the similar one which
that we have answered.
Yes, and please let us know where to dispose the spray bottles.
Very good question. Whoever has asked, spray bottle cannot go into the yellow. Spray bottle cannot go into the red. Edikandre, it is what do you call? It is a pressurized container. Blast agate. So it should go into hazardous waste. It should basically separate it out, and it should go as hazardous waste. All pressurized canisters and all should go as hazardous waste, which have the potential to cause for blast and for burning. I mean, blast and fire.
Okay. Thanks, sir. So I think if there are any other questions, you can put it on the chat box, which will be addressed at the end. So that's it from.
Okay. Yes. Thank you, Akshay. It was very useful you reading the question. So just to summarize this small thing, Pooja, just to summarize the small things. So we have the homework.
Pooja,
the homework is we have to give solution for the X-rays in small hospitals, and copper T is repeatedly asked. So we will prepare some 4-5 points SOP for copper T management also.
Sir, there are 3 more questions from DHQM. We
Ah.
already put it in the chat box.
Chat box. Okay, ನಾನು ನೋಡ್ತೀನಿ. Let the next session start.
Hello.
Yes. Yes.
Hello, sir.
Okay.
Hello.
Manju,
Yes, sir.
with your permission, before you start, Manju, with your permission,
Yes, yes.
electrodes way to put anta ಹಾಕಿದ್ದಾರೆ. Electrodes are considered as electronic waste, electronic waste. So it has to go as per the hazardous waste management rules. Thank you, Manju. Thanks a lot.
Okay, sir. Good afternoon, all.
I'll welcome you, sir.
Thank you, madam.
Thank you so much, Akshay sir and Ramkrishna Gaud sir for answering the queries. Now we will move on to next session on biomedical waste in context of COVID-19 scenario by Dr. Manjunath S. Nekar sir, Associate Professor, Department of Community Medicine, KIMS Hospital, Hubballi. Over to you, sir.
Thank you, madam. Whether the slide is visible, PowerPoint?
Yes, sir, it's visible, sir.
Thank you. Good afternoon, all. Here in this session, I'll be speaking on biomedical waste with perspective of COVID-19. What were the challenges? What were the crisis, and how we could able to manage those things? Because when Corona pandemic arrived, we were unprepared for so many things. So we'll go through the slides and we'll come to know those things. So COVID underlined the importance of biomedical waste management. That is, earlier also biomedical waste were very much, it was not that much priority for so many administrators and also for the healthcare providers. But COVID, it because of this increased waste, biomedical waste. So still again, the people has to take care, has to focus on management of the biomedical waste. India generated about 101 metric tons per day of COVID-19 related to biomedical waste, peak about 203 tons per day during the second wave. So routinely 600 metric ton biomedical waste generated, and 500 grams to 2.5 to 4 kg biomedical waste per bed was generated. And India has generated 32,996 MT of COVID-19 waste between the June and December 2020. So when we see the stat, these are staggering numbers, because already the whatever the common treatment facilities were there, they were resource were already at exhaustive level, and over and above that, the COVID has given them still more headache. They had to revitalize their capacity to manage the biomedical waste. So in coming slides, you can see that how the biomedical waste was increased during the COVID. So yeah, the blue color is the September 2020, that is the first wave, and orange is the during the second wave. So the biomedical waste generation is directly proportional to the number of cases. As the number of cases increased, even the
remaining
biomedical waste.
but our ಹೇಳಿದ್ದು ಅದು
Hello, I am audible?
Yes, sir, you are audible, sir.
Okay. As the number of cases increased, the biomedical waste also increased. The slide shows that as the number of cases increased, even the biomedical waste generation also increased. During this time, there are so many challenges were there. Like healthcare facilities, the use of PPE has increased. Earlier, this personal protective equipment were used only exclusively in the operation theater. They were never seen outside. Maybe in some of the hospital, it was used even in the ICUs, but never in the wards. But COVID made us to use these PPE as and when required even in the wards also. So there were huge quantum of the waste was generated, and also there was a lack of awareness about segregation and impact on the environment. When we started using the PPEs, some of the PPE, it was plastic was also there. As a face shield, it was attached to the hood. So there were, and also how to segregate, and regular biomedical waste bins were not at all enough for these PPEs to store. If you put one PPE, it was over. Where to put the other PPEs? Earlier, one dustbin was enough for the almost half day, or if it is a casualty, you used to lift 2 to 3 times a day. But after using PPEs, it was becoming very, the quantum has increased, so it has to be lifted very frequently. And the biomedical waste bins were also inadequate. And the community generation, even in at the domestic level, at the household level also, the people started to use the gloves. Whenever they go outside, they started to use the gloves, and also they started using the face mask. So after using, where to discard it? So that was the challenge, to educate the people. So it was never this biomedical waste disposal was never, even in the hospital only, it is very difficult to manage. Now even it has to be managed at the community level. So people has to be told how to dispose it, and operationalization of the waste collection at the household level. So, and at this time, the waste handlers or the waste pickers from the municipality, even they were also not ready to come. If there is any, please, Nutan, someone is scratching on the slide. Even at the earlier stage, even one case was there, means there used to be 5 kilometers of quarantine was imposed. So that time, how to collect the waste from that particular home or around that house. So even the waste collectors were also reluctant to collect the waste from that particular house. They were also not ready. So we needed to tell people how it spread, and how the face mask can be disinfected even with the simple soap water. If they dip the face mask in soap water for 15 minutes, and after that it becomes disinfected, and not even sodium hypochlorite is not needed. Soap water was enough. So after that, they could, it can be discarded as a general waste. So community awareness and engagement was a major thing. And when the healthcare, when the COVID started, it was very tough for the hospital to run, and many people were they left the job itself. They were reluctant to join the duty. Healthcare workers were not ready to work, and we needed already, as we saw in previous slides, the waste generation was increased enormously. At the same time, workers were not there. There was no new staff for the biomedical waste management. As I told, the biomedical waste management is always secondary or priority. And also the people who were working, they were also apprehensive. Oh, what will happen to me? I have an old mother in my home. Someone was telling, my small kid is there, 1 year kid is there in the home. How can I lift the waste? If I get, what will happen to family members? So it was a lot of resistance was there to work. Sorry. Lot of resistance was there from the people who were working in the biomedical waste management. So later we needed to train them. We needed to assure our support. A separate ward was created for the all the healthcare workers, not only biomedical waste, even the nursing officers, doctors, technicians, for everyone together. We assured them there will be a bed for them. So there was challenges to bring them to the work, and segregation was difficult. Yeah, because when we train the who work in the hospital, but here we needed to train even the patients also. For example, leftover food by the COVID patients, where it has to be put. At the earlier stages, for 1 or 2 weeks, there was confusion was there where to it has to be put, whether it has to go to the general waste or it has to go to the yellow color, because a COVID patient has touched it. Because of his saliva will be there in that. So a lot of apprehension was there how to handle the especially leftover food by the COVID patients. So later, with I must thank UNIDO team for and Pollution Control Board. They gave us the directives that the leftover food has to be separately collected and it has to go to the general waste. And we enhanced the training of the workers regularly. Training of the workers was also a challenge because we cannot the workers were always busy. As I mentioned previously, the workers number of workers was less. Almost all were in the workstations. So to even to take them for the training session also it was difficult. And also the workers, it was a completely new one that is wearing the PPE kit because how to you PPE kit where they will never use that, and it was they have to use wear that and they have to roam around. It was not comfortable at all for them. So slowly we trained them and we retrained whatever queries were there. We solved, and by God grace, in KIMS Hubli, the biomedical waste handlers or the staff who we have been involved in biomedical waste management. Nobody, there were no morbidity due to COVID. So maybe because of the better following up the directives. So what is this COVID biomedical waste? That is biomedical waste generated during the diagnostic and treatment of the COVID-19 suspected or confirmed patient, including isolation wards, quarantine centers, sample collection centers, laboratories, ULBs, common biomedical waste treatment and disposal facilities, in addition to existing practices under Biomedical Waste Management Rules 2016. As we see, diagnostic is we take the nasal and the throat swabs that will go to after we send it to the microbiology lab. After that, it will be discarded in the yellow. Even the plastic outside is there because it has the infectious agent. It used to be, we used to send it by the yellow color. And the plastic one, we used to put it in the red, and gloves also in the red. And the PPE kit, if it has the, it doesn't have the plastic in it attached to it, we used to put it in the yellow color. Only if it has the plastic like in face shield, it will be put it into red color. So diagnosis in the fever clinic, RT-PCR test we do, and waste generated from the COVID wars, including the PPEs, personal protective equipments like gloves, aprons, gowns, all those things. And immunization, even immunization was also a major challenge because it was generating a lot of sharp waste. And after the sharp needles, we used to put it in the white container, in puncture-proof container. But the problem was with the cotton swabs. The cotton swab, after giving the injection, the nursing officer will be giving that cotton swab, used to leave there only, and we used to ask them to put in a yellow color bin. But as usual, it was never put it into the yellow color bin. So yeah, then their whims and fancies, they used to throw, or they used to put whatever the dustbin they encounter. In KIMS itself, we had given more than 1.5 lakh of immunization we have done here in KIMS Hubli. So why we are talking about this biomedical waste of the COVID? That is, biomedical waste has potential to spread infection, including COVID-19, and is a real problem for environment and human health. Improper disposal can release high levels of unintentional POPs, or persistent pollutants of the environment, that is dioxin and furans. And biomedical waste management requires life cycle approach. That is, we have to, it has to be, the management has to start where it generates, point of generation. From there, it has to be followed. Unscientific disposal of biomedical waste causes adverse impact on public health and occupational risk. So we have seen that many doctors, nursing officers, they have paid their lives for the COVID. So in care of patient, they had acquired COVID, and many doctors and nursing officer, technicians, they have lost their lives. Maybe because of the improper disposal of the waste, or improper use of the protective gears. So there are so many reasons. Guidelines and rules related to COVID-19 biomedical waste management, and they were given on by CPCB on March 18th, 2020, revised on 25th March, 18th April, 10th June, and 21st July 2020. Biomedical waste management rule 2016 is been cornerstone in this life cycle approach. So COVID-19 biomedical waste generation. So here also segregation at point of generation. This is the one of the most important step in management of the biomedical waste, be it is a COVID or any waste. Segregation is the cornerstone. Without segregation, whatever the steps we tell next, it cannot be implemented. Only if the waste is segregated, the next steps can be applied. So segregation at the point of generation is one of the most important steps. After the segregation at the point of generation, there will be intramural transportation in the closed trolley. From there, it has to be stored in a secured storage. Then from there, for KIMS, we have a temporary storage room is being built with the help of UNIDO project. So it's been stored there. From there, it will be transported to common biomedical waste treatment facility. Sometimes we used to give directly, we used to call the biomedical waste transport vehicle twice in a day. It was so much of waste generation was there. We used to transport directly into the vehicle itself, and final treatment at the common biomedical waste facility. Then after that, disposal. So these are the incinerators for the yellow color waste. So this has been in detail has been spoken by my previous speakers, the Gaud sir and Dr. Akshay. So here in COVID-19, with respect to COVID-19, the which we have to be more worried about face mask. Face mask has to be put it into yellow color bin. So for this sake, we had kept yellow color dustbins even in the college entrance also. As soon as the in the college entrance near the ATM machine, so wherever it was possible, we have kept the yellow color so that even the general public can discard their face mask in the yellow color bin only. And PPEs has to be put into yellow color, and broken or discarded contaminated glassware in the blue, red. Mainly the gloves has to be put here, and metallic sharps and auto-disable syringes. So especially from the immunization point centers, so we they were put it into this because auto-disable syringes were there, where needle is fixed to the syringe. And here in COVID-19 biomedical waste guidelines, they some of the important points were that we needed to separate labeled color coded bins has to be put for the COVID separately, so that it was not put it into queue. When it reaches the common treatment facility, it was not put in the queue for the final treatment, that is for the incineration. As soon as it reaches the common treatment facility, it was put directly into the incineration. So only for that sake, we needed to separately label the bins, that is COVID-19 waste. And foot operated color coded bins were compulsory, and they were double layered, color coded. These are non-chlorinated bags to ensure adequate strength and leak proof. As I mentioned, the amount of waste generated was very huge. So the amount, the number of waste will be more. Hello. So they were, we have been asked to put double layered, color coded, non-chlorinated bags in the dustbins, in dedicated closed trolley for transportation of the biomedical waste from isolation wards to the storage room. Clean the inner and outer surface of the trolley with 1% sodium hypochlorite solution, and storing the COVID-19 biomedical waste separately in storage room. Our preferred is that biomedical waste from the isolation ICU or ward shifted directly to the transportation vehicle of the common biomedical waste treatment facility. So we almost all may for a whole pandemic time, we have shifted directly from the wards to the transportation vehicle. And label the bins, bags, and trolleys as COVID-19, and maintain the separate record. And we provided all the required PPEs to our sanitation staffs. So we could able to, whatever their apprehensions were there, we could able to ward up because of a proper, we gave them as and when required any personal protective equipment, whether it is the gloves or gowns, face shield, or the shoes, gum boots, or whatever they required, we gave them, and we could able to run the show. Dedicated staffs for handling the COVID biomedical waste and solid waste. Segregation at the point of generation, it was the main point where it was a difficult one, as I told, because even the patients were also involved in generation of the waste. So in starting, in initial period, it was a bit difficult to see the because we couldn't able to go inside frequently to see what's going on. Every time if you go, we have to use the PP, or in that time PP were also not much available. So logistic problem was also there. So we couldn't able to monitor it, but later we could able to improve on that. Training to all the staff involved in biomedical waste handling. We did it many times. Regularly, we did the training. And general solid waste segregated as per the solid waste management rules of 2016. And we collected the wet waste like food waste, fruit peels, dry waste separately. And also in the wards, we used to make in COVID, in first wave and second wave, there, especially everyone knows that the COVID patient, they had lost the, hello, they lost the taste. I request everyone to mute yourself, please. They had a loss of taste. So whatever the food you give, whether you give from the hospital or from the home, it was not tasting good. So there are a lot of food waste was there. So for that sake, we made compulsory that it has to be, they have the food from the home was banned. Even whatever the quality was there from the hospital, it was improved, and slowly patient could able to appreciate the work done, food given by the hospital, and so that we could able to reduce the generation of the food waste at the source itself. Earlier, when we allowed waste food from the house, they used to give them a lot of food in the hope that they will eat and they will recover fast. But the patient, due to loss of taste, they never eat it even quarter of that, whatever given by the house. So we banned it, and we could able to reduce the food waste and spray 1% to sodium hypochlorite solution to the segregated general solid waste and hand over to VLB, and minimize use of the disposal items. And on all these things we have discussed. This: do not mix the general waste and COVID-19 biomedical waste, and do not disinfect the yellow bag with sodium hypochlorite solution, because it is double layered. There is no need to disinfect it. Do not handle COVID-19 biomedical waste without proper label to the CTF, because as I told, the biomedical waste from the COVID-19 was separately, it was given priority in treatment. So it has to be properly labeled. And do not transport COVID-19 biomedical waste in open trolleys. As it is, droplet spread will be there. So it has to be closed transportation is required. And use of the PPE. And when we conducted surveys regarding the biomedical waste in North Karnataka, we saw that even the people who are sitting at the immunization center, at the reception center, even they were also using the PPE kit. That is not at all needed. So PPE, so only this slide shows where to use which type of PPEs. So just because of apprehension, ಸುಮ್ಮನೆ ಹೆದರ್ಕೊಂಡು ಎಲ್ಲ ಕಡೆನೂ PPE kit ಹಾಕೊಂಡು ಕೂತ್ಕೋತಾ ಇದ್ರು. So that was not needed. Indirectly, it was taxing the environment. In low risk area, triple layer medical mask is enough with the gloves, like help desk or reception. In moderate risk area like laundry, CSST, N95 mask and gloves are enough. In high risk area like lab, critical care area, ICUs, wards, full complement of personal protective equipment, goggles, face shield, mask, gloves, coverall, gowns, head cover, shoe cover, all needed in high risk area only. If in doubt, So you have to ask whether it is a infectious soil waste that can be incinerated, so that if you are in doubt where to discard which one where, so you have to ask this question: is it an infectious soil waste that can be incinerated? Then you have to put it in the yellow. Is it a disposable, recyclable plastic? Then it has to be put it into red. Is it a reusable glassware? Is it a metallic share? Sorry, it is not share, it is sharp that can cause injury. So that has to be put in white, glassware in the blue. So COVID has underlined the importance of biomedical waste management. Even now many people know that importance of managing the biomedical waste. However, it needs to be strengthened. Attitude has changed to some extent, at least now. Now people will not cough on your face, at least. Definition and clear definition of COVID-19 waste. Core principle of 3 R's, that is reduce the use, generation of the waste, recycle wherever it is necessary, or reuse wherever it implies. Need for augmenting the capacity of the common biomedical waste treatment facility, as I told, because of enormous, within a short span of time, there was a lot of waste was generated, more than what it could handle. So now we need to augment the capacity of the common biomedical waste treatment facilities. So learnings from the COVID pandemic: follow the CPCB guidelines and the national regulations. Treat coronavirus waste as any infectious waste. So you need not, apprehension is not needed. When we can able to handle even HIV, the more infectious hepatitis B infections, coronavirus is not that much. So nothing to worry about it. Segregation of the waste at source. This is the, I'll reiterate, this is segregation of waste at the source is the most important point. Dispose in an infectious waste in foot operated bin with a suitable color coded liner. Proper handling of collection, transport and storage. Use appropriate PPE at appropriate place. So maintain a hand hygiene. Use safe and environmentally sound treatment methods. Centralized treatment facility using autoclave or microwaves wherever it is necessary. Hybrid stream system, microwaves, eco-friendly treatment methods if it is available. Disfigurement of used mask and other PPEs, especially the mask, these strings, if you just throw it in the if you throw it in the dustbins, these strings will be strangle the many birds or small animals. They are very dangerous for them. So we have to, and also it can be reused by unethical people. So it has to be, whenever you discard your mask or PPEs, it has to be disfigured. Follow routine disinfection and cleaning protocols for the waste bins. So we have to follow life cycle approach from the point of source to the final disposal, and extended producer responsibility. Whoever generate the waste, they have to take their own responsibility for that. You shouldn't ask someone else to, after you down up, whether it is a doctor or anyone. If you remove your PPE, you have to put it in the appropriate dustbin. Not do not expect someone else to put it in the dustbin. Startups for better alternate waste management solutions and recycling. Identifying the infrastructure gaps and leveraging the technology. Awareness among the healthcare workers and occupational safety. So it is occupational safety issue, environmental safety issue, or attitudinal. or patient safety issue. So for the videos, you can go for you can go to this link and you can watch the videos. These are my references. And for this PPT, I acknowledge the help by the MPRI. Help given by the MPRI, UNIDO, and my parental institution, MS Rai Medical College, the Central Pollution Control Board, Government of India, management of Gokula Education Foundation, Principal and Dean MS Ramaya Medical College, faculty and PGs, Department of Community Medicine, MS Ramaya, where my all teachers are there, especially Dr. Prithvish, Dr. Gopinath, Dr. Hemant, Dr. Suman, Dr. Lalita, Dr. Dayanand. There are so many other names are there. And my colleagues, Dr. Akshay and Dr. Shankar, I acknowledge their help in preparing this PowerPoint. Thank you.
Thank you so much, Dr. Manjunath, sir. Participants, if you have any queries, you can ask now. Ramkrishna, sir, are you there?
Yes,
Dr. Ramakrishna, sir?
Sir is in a process of logging in through his phone. He's
Heli ma.
busy with some
Akshay,
other
Akshay,
meeting.
I'm here.
Sir is
I'm
there.
here.
Yes. Yeah, sir, there are a couple of quick questions which I would like to put forward. One
Yes,
is
gentlemen.
how to go about managing dialysis line and dialyzer, which is one question. So, dialysis bloodlines and dialyzer.
Dialysis bloodlines. That is, it has to go to red.
No, first thing is, okay.
Sir, Gaud sir, you need to unmute. Yes, just a minute before that. Yeah, how to manage routine immunization waste. I think this shouldn't be a problem at all, because we know what are the things which are generated through our routine immunization, and it has to go through the appropriate yellow, red and blue colored bins, whichever are appropriate. So I don't think this is a difficult question actually. So whatever are there as far as the guidelines are concerned, you need to follow that. And yes, there was a question regarding dialysis bloodlines and dialyzer. Sir will shed more light on this, because I'm not. And how to go about, can we have separate guidelines for disposal and collection of rejected waste, hazardous waste? Like, yes, sir.
Sorry, dialysis,
sir,
what I missed, bad connectivity.
Sir, dialyzing bloodlines and dialyzer ಬಗ್ಗೆ question ಇದೆ sir ಒಂದು.
Okay.
How to go about
dialyzer
disposal
and
of this?
dialyzing bloodline. Is it
Yes.
metal? Is it plastic? If it is plastic, it will go into the red. If dialyzer ಏನು ಅಂತ. Hello.
Yes. Dialyzer ಏನು ಅಂತ ಹೇಳಿ ಹೇಳ್ಬೋದಾ? What is the dialyzer which is being used?
Is it a
Sir, I think it's a liquid which is being used.
Yeah, it's chemical. It will be deemed as a chemical
Yes.
waste, and it will go as per the ETP. It has to be linked to the ETP, and it will go. If they do not have a
Okay.
ETP facility, then that will be managed as per the KHSDP, that manual what we mentioned, which will be shared with them. They should manage it as per that norm.
Okay, sir, there is one question which is can we have separate guidelines for disposal and collection of rejected waste or hazardous waste, like fixed day collection of these wastes?
That is hazardous waste management rules. Please make a distinction between biomedical waste management rules and hazardous waste management rules. These things will come under the hazardous waste management rules. These new chemicals you use, martira, mercury and all that, it should be managed as per the hazardous waste management rules. First, in the absence of any solution, you have to contain it. So, like the way we tell for mercury, you first collect and contain safely using all the precautions. You contain it. Then you have to hand it over to the hazardous waste management facility people. That solutions you have to find at your district and taluka level.
Okay, what about expired medications and remaining vials? It has been told earlier, yes.
Yeah, it is pharmaceutical waste. Again, contain that in the yellow container very specifically, only pharmaceutical waste. Label it. You keep it. That can be collected periodically, once in 2 months or 3 months, depending upon the amount of waste that you generate. And it can be handed over in one go to the common treatment facility. It need not be done. More syringes, more vials, we need not send it. We can store it. Since they are not infected, these medicines can be stored in the healthcare facility. No problem. They can be sent once in 2 months or once in 3 months, depending upon your understanding and understanding between you and the common biomedical waste treatment facility.
Okay, so there has been a request for sending the link for the manual. So it will be sent from the MT team along with the resources or the presentations. So it can be used at your local institutions for sensitization also.
Okay. So Andre, Akshay, we have Pooja. Please, we have to ensure that we share these things immediately. Then we will lose our participants. So as much as I can gather today, these are the following things we must share with our Mangalore friends. UNIDO guidelines. So, ಮತ್ತೆ ಇದು ಏನಂತೀರಿ Pooja, just hazardous waste management rules 2016. Send that also one copy. Let our participants know. Then number 3, we have to give some 4 or 5 step guideline for cooperative waste management and also the X-ray films.
Sure, sir.
Okay. Please make a note of it. Put that in our WhatsApp so that all of us are reminded, and we'll 100% get back to our Dakshina Kannada friends.
Okay, sir.
ಇದು ರ್ಯಾನ್ ಎಲ್ಲಿ ಕುತ್ಕೊಂತಾರೆ?
Yes.
Administration unit.
I think that's it from our side, Pooja. You can take over.
Participants, if you have any questions?
Akshay, I'm repeating, Akshay.
Yes, sir. Sir, you are not audible.
I'm getting into a meeting. I will leave the meeting.
Yes, sir. Yes.
Akshay,
yes,
we will get back to our participants 100%.
Yes. Yes.
All the questions will be answered. Okay.
Yes.
Thank you, Ramakrishna.
Thank
sir.
you. Thank you, sir.
Thanks, Manimellargu. Thanks. Bye.
Thank you so much, sir. Thank you, Akshay, sir. And thank you, Manjunath, sir, and Prithvish, sir, for your valuable information regarding the biomedical waste management. Thank you so much. Thank you, participants, and thank you for who participants who have joined from medical and paramedical staff, staff from veterinary and general public, and DHQM from Dakshina Kannada. Thank you all.